Hey guys.
Hey everybody. No need to adjust your camera. What they call this in Grenada is a tan. It's a work in progress. If I sound a little raspy, we had a boat party yesterday and I'm mildly recovering. But Lindsey's gonna start off. So hope y'all are doing good. We'll cover pulmonary. We've done the pulmonary renal thing on the same day and it's just so much. So we figured we could do pulmonary now and then cover the renal stuff next week. Just so you know, renal, people tend to have trouble with renal, but the exam isn't as bad as some of the material leads on. But we'll worry about that next week. We'll cover the pulmonary stuff today. And yeah, we'll go from there. Y'all exam is the 3rd, correct? Is that right?
That's the day we start.
Is it the 3rd?
Yeah.
Anyone? Yes, 3rd. Okay. Yeah, we start on the 3rd. Right. So we'll do one. We'll figure out what day to do it next week. Yeah. Does that work? Yeah, that works.
Yeah, we are. Yeah.
25th. No, wait. Oh, sorry. Okay, yeah, that works. We'll probably do it Saturday since your exam is that. All right, cool. Let me open the chat. Okay, so since y'all's exam is Tuesday, we should probably do renal on Saturday. We're doing the term 3 final exam. I don't think their exam is till Friday. So since y'all's is sooner, we'll plan to do it Saturday. That way you'll have time. Okay. So I think we're good. Let's go ahead and get started. Y'all are used to this now. If you go to the Scrubs page, term 1, that's how you access the videos. It'll bring you here. They're private, so if you bookmark the playlist, you can access them that way. This is not affiliated with school or anything like that, but go ahead and join IEA's group so you can follow along. We're going to do questions of the day and stuff. For you guys that are fortunate enough to make honors, y'all will be able to apply in August for IEA. So we're going to do a bunch of events down here. We're going to have a party, some fundraisers. We do offer tutoring too. So join it so you can follow along. And yeah. Oh, also, I just let y'all know, I posted on Scrubs just this Word document, a 1-page document about traveling, just kind of some of the speed bumps I came across that made it easier for me, things I didn't know just going in. So if you read through that, it may make the traveling process a little less painful. I could tell you that I had all my paperwork in order and it was still a bit stressful. So once you get here, all seems to work out well. But if you follow along on the little paperwork I gave, it should kind of clear up a lot of the issues you might be curious about. Okay, I'm on Scrubs. Lindsey runs Dog Mom. Always check out our drive. We have extra questions, charts, whatever, anything that was given to us in the past. We try to put it on there so y'all have resources y'all can look at. All right, Lindsey, how are you?
I'm going to request access to your screen.
Do it. Hands off.
Sit on your hands.
Yes, ma'am.
Okay, so we are starting with the lymphatic system. So for your purposes in term 1, oh my God, I had to think about that for a second. All of y'all's terms are running together now. This is very basic. And so this is an introduction into the lymphatic system. So just know that it's going to be, you're not sitting on your hands. Just know that it is going to be more basic. The information you need to know is going to be an introduction into what you're going to get into in term 3 and term 4. So don't stress about it too much right now. Learn what you need to learn, accept it, and move on, essentially. So the lymphatic system is made up of cells and organs. Cells, you have the lymphocytes, NK cells, B lymphocytes, antigen presenting cells. Organs, you have primary, bone marrow, and thymus. It's primary because that is where those cells originate. And then secondary, this is where the lymphatic immune cells are going to come into contact with antigen. And so that is where the immune response is going to originate.
Sorry, Lindsey, I don't mean to cut you off. Before Keisha might have to run. I know a lot of people. Keisha, are you there still?
Yeah.
Yep, loud and
Okay,
clear.
so I know a lot of you had questions about the lab exam and the OSCE. When Lindsey and we were shipped home, our term 1, so we did not take them, but Kishore, he's term 3, so he could give you all some insight real quick on how to prepare for that. So go ahead, Kishore.
It's going to be quick. I'll try to cover everything that I mentioned in the previous session. What you guys need to do essentially for preparation for both the OSCEs and the lab exam is, one, be aware that it's not the biggest bucket of points that you're going to get during this entire like T1 experience. So one, be aware of that and know that the bigger fish that you have to fry is definitely going to be the CPR2 exam. So just prefacing that, if you guys do need to prep and you feel like you're pretty wobbly on a couple of the things that was mentioned during MSK and some of the anatomy concepts for the lab exam, make sure you guys watch the reviews for Brady and Lindsey's that are on YouTube, and that will help a bunch, as well as review the document that I had shared with folks that basically had all of the cadaver images compiled. It has a little bit more than you guys need because it covers other organ systems and modules that you haven't technically covered yet. But I can share that with you guys again on the, here's the TPLG page, and I can share it along with to DocMom as well as Scrubs. But that one has essentially all of the cadaver images. You guys, they won't ask base level questions of just purely like, oh, name this muscle. They typically will either give you like a second order or a third order question with this. If there's an embryological origin or a factor that plays into how this muscle receives blood supply, they can ask that. So you got to start thinking of those second and third order question, because it's never just going to be like, here's this structure, name it. That's for the lab exam. For the OSCEs, I also compiled a document that has all of the small group stuff for any of the physical assessments. And I have highlighted all of the key stuff that they ask about, such as like the specific numbers, like how far you have to palpate, how much edema you would be measuring, like what scale you would use. There's all sorts of components, like how you measure the cervical to thoracic to the lumbar, and how you can kind of trace everything step by step. So it's essential that you guys go through that. They really do, since we're in online format and you're doing this in person, they really care about those like tiny details of like the numbers, the dates, as like how many, respiratory breaths you got to measure before you can make accurate calculations. So they like those little details. I told that to a bunch of people who messaged me. Keep that in mind. Look at the stuff that I've highlighted, and make sure you guys go over the practice questions that are often floating around on the various DES pages. They're not the most accurate as to what it's going to show up on the exam, but it is helpful to constantly test yourself on this material. That's my spiel. If you guys have any other questions, I'm happy to answer them for another like 2 or 3 minutes before like Brady and Lindsey take over.
Something that I did for the term 2 lab exam is I screenshotted the quiz they give you, and I screenshotted all of the referenced atlas pictures and I put them in my OneNote, and I would make sure that I could label every single structure on that slide, and that if they asked a second order or third order question for a specific structure, I made sure that I could answer that second order or third order question for every structure in that picture. And so, I mean, that was term 2. Term 1 is a little more extensive because you do have MSK and you go over so much stuff, but that is a strategy that proved effective for me in term 2. And it's a strategy that I passed on to Kishore's class, and they found it effective for their term 2 as well. And so it might be useful for you guys to kind of model that for term 1, because it is how they think when they do these exams, when they write these exams.
It's a little bit more extensive in T1 because you got so much MSK, but T2, it gets so much better. It's very much more targeted as to like what organ, what system that you're likely dealing with. T1, they can literally ask you anything from MSK, and you guys basically cover the entire human body in like a span of 4 weeks. So it's a lot. So screenshot those quizzes. I think some of the lab images, the cadaver images, are already on the slides that I have compiled. I'll put those links out onto the Facebook pages in a hot minute so that you guys can access them from there. They're on my Notability, but literally anyone can download them either as a PDF, or if you want to directly import it into your Notability, you can do that as well. Just don't circulate it around because technically it's still SGU material. So just saying. Okay, that's my spiel. Feel free to direct message me or Cassidy too. We both got through the lab exam. We did perfectly fine. So we're here. You can also message Brady and Lindsey too.
Awesome. Thanks, Kishore. Okay, we ready? Okay, I'm controlling your screen now, Brady. So again, just reach out to them if you have any specific questions for that. Brady and I did not take those exams. So there you go too. Okay, so back to the lymph system. Again, you have the cells. Primary is where they're made, secondary where they're introduced to antigen. So just overview, you need to know that. Okay, with the cells, T lymphocytes, they differentiate in the thymus. Yes, you need to know that. Something that they might talk about with you guys, I don't know if they would here, but they always like to reference to George with respect to the thymus because you don't have it, and so you get repeated infections. So that's just a clinical correlate that they like to bring up. They have receptors for that recognize antigen, and so they will have an MHC molecule. I'm going to talk about that when I talk about the ABCs. You have different kinds of the T helpers, cytotoxic. Yes, you do need to know the difference between these. So the helper cells are going to recognize the antigen on the antigen presenting cells. They're going to synthesize interleukins, and they are associated with CD4. So CD4 is associated with MHC2. Again, I'm going to talk about that in a sec. I just put this on here for your reference. So underneath the T helpers, you have T helper 1s, T helpers 2s. The difference is intracellular versus extracellular pathogens. And then you have cytotoxic, which are going to be antigens on cells infected with cancer or viral particles. So essentially, if a cell is infected, it's basically saying, hey guys, look over here, look at me, somebody is trying to attack me. And then the T helpers, the cytotoxic lymphocytes will recognize that and they'll kill that cell because it's infected. And then that's associated with CD8. Yes, you need to know what CDs are associated with all of these. There are a couple that they emphasize in the lectures that they bold for you. Definitely know those, but those are easy points if you can associate the different CDs with the different cells at this point. It's very minimal for you in term 1. So just look over that, take a couple minutes so that you don't miss a point on the exam. B lymphocytes, this is humoral immunity. This is the memory cells, so antigen binding site. They have a B cell receptor, and these are associated with MHC2. You have the plasma cells, memory B cells. So this basically what you need to know: B cells, what they are, and then the CDs associated with them. So 9, 19, 20, and 40, those are very characteristic of B cells. Natural killer, this is innate immunity. So you don't need prior recognition for this. It's just these are killer cells, so releasing granzymes and perforins to form to impugn the integrity of the cell membrane, and that's how they're going to kill their cells. They do have FC receptors, lyse cells coded by immunoglobulin or complement. Those are their CDs. And then the antigen presenting cells, you do need to know MHC is associated with CD4, MHC2 with CD4, and MHC1 with CD8. I have a little corny, simple way to remember it. So when I write a 4, I use 2 lines to write a 4, whereas if I do an 8, I use 1 line to draw an 8. And so it's a weird way to remember it, but I've never forgotten it since then. So sometimes the corniest, most simple. What just happened? Sorry, guys. Oh, you skipped ahead far. Wow. Okay, thanks. Sometimes the simplest, most corny things are the things that stick with you the most. So that's how I remember it. Kupfer, Langerhans, dendritic cells. These are just names of these cells in other places. So you're talking about macrophages here, where they just gobble up essentially everything that is foreign in the vicinity. And so depending on the location, they will be called different things. So liver, Kupfer, skin, Langerhans, and then spleen, lymph nodes, you have the dendritic cells. So let's answer this question. Yeah, so as always, private message in the Zoom chat, Brady or myself with your answer. Yeah, you guys are getting it. If I make like painful faces and I adjust myself during this, just know that I had 2 skin excisions, one on my butt cheek and then one on my stomach. And so every once in a while I get a really severe twinge of pain and I have to adjust myself. So that's why I'm acting kind of off today. Okay, all of you are pretty much getting it right. The answer is D, cytotoxic lymphocytes. And so this is viral particles. Remember, if a cell is infected with a viral particle, it will kind of send a signal, or it'll put a signal on its cell membrane that says, hey, 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 I'm infected, I'm infected. And the cytotoxic lymphocytes can kill those so that they can't spread. So the viral particle can't spread and the infection is minimized. So one more question. Thanks for all the well wishes privately, guys. Oh, okay. Well, I gave you the answer, but let's go through this and figure out why NK cells is the answer. So we have a sore throat, he's flushed and lethargic in the early stages of the disease, innate immune cells. So that's a big thing, innate. So this isn't a memory kind of thing. This isn't something that an immunity you built up over time. So it's an innate immune cell, release granzymes and perforins to induce apoptosis in the infecting cells. So, release of granzymes and perforins, this is going to be your natural killer cells. So that's the answer. One more. You guys are between 2 answers, and I understand why you're between 2 answers. The biggest thing I want you to look at is the MHCs. That's going to be a big, big hint there. But yeah, good majority, you're getting the answer to this question. It's macrophage. And it says, showed myeloid lineage with both MHC1 and MHC2 and CD40 on its surface. Macrophages are going to have MHC1 and MHC2 to interact with both B cells and T cells. The reason why you want these to interact with both of them is because the T cells are going to really be that more innate immunity, or it's not innate a good reaction, whereas the B cells is going to be memory. So you can say, oh, hey, B cells, remember when we saw this last time? And then your T cells, you have the CD8 CD4 T cells. And so you want to initiate both arms of the immune system here. So that's why you're having both presented on its cell surface. Okay, now we're going to go to identification. This is pretty high yield on your exam. You need to be able to look at a slide, and if you are able to identify, it will narrow down a lot of stuff for you. And so it's really important that you can recognize both on histological slide and in the description and function what these different ones are, what these organs are. And so we're going to go through how you can tell the difference between these, because this was really hard for me. Okay, lymphatic tissue. This is non-encapsulated localized accumulation of immune cells. So walls of GI, resp, and GU, that's genitourinary. So this makes sense because any opening to the body, any connection to the outside world, you need lymphatic tissue there. You need it there, because that's going to be a big site where you're going to come in contact with foreign material. And so you have this immune tissue there. It's not encapsulated. That makes sense because you don't need just like an encapsulated organ in one place. This is diffuse. It's lining the entire area so that if you have something coming into contact with these areas, that you have a response there. So it's basically protecting you against the outside world at that location. So diffuse lymphatic tissue, that's what this is. And so I feel like I need to change these slides because I had a little fun with them, but you don't see this thick capsule right here. You see an accumulation right here, but you don't see a thick capsule, a thick eosinophilic or basophilic capsule right here. And so you'll see these accumulations, but it's going to be more diffuse. It's not going to be localized. Thymus. This is where you have T cell maturation. So some things about this that are pretty high yield: no afferent lymphatics. It has continuous capillaries. What does that mean? If it's not fenestrated, you don't have the openings for things. Third pouch, that's its embryologic origin. And then you have a capsule with connective tissue extensions, trabeculae that divide the tissue into lobules. And that's what you see here. And this is going to be a really big identifier that you are in the thymus. So you guys can't see. Do I have a pointer? Okay, well, you see the thick white capsule. That's your big identifier, these trabeculations that are going to divide to the lobules. And then when you see the lobules, you see this thick cortex and inner medulla. So that's very characteristic of this area. So in the cortex, you have the immature T lymphocytes. This is where you are going to do a lot of selecting for them. You don't need to know that in term one. What you need to know is that in the cortex, you want to wall it off from everything else. So these are cells that haven't yet learned how to be T cells. And so you need to keep them away from antigen, because if they haven't learned how to be a good T cell and they interact with an antigen, bad things can happen. So the way you do that is these epithelial reticular cells, the ERCs. So they're providing support and they surround the vasculature to form the barrier. So sequestering, we need this barrier. Cortex, you just have all of these immature T lymphocytes in there, and that as they move through the cortex, they get more and more and more mature. They learn how to be a good T cell. Then when they graduate, they can move into the medullary area. So mature T cells migrate into the medullary blood vessels and efferent lymphatics. You no longer have ERCs in this area. They're degenerating. They're forming Hassel's corpuscles, which is also a defining feature of this area, the Hassel's corpuscles in the medulla. And so this is where you can start maybe seeing antigen, and then you're doing more selection. Again, not a term one thing, but what you do need to know is the difference between the cortex and the medulla. The ERCs are very tight and profound in the cortex, and the medulla, they're degenerating to form Hassel's corpuscles because you no longer need that sequestration from the rest of the system. Lymph nodes, you have lymph nodes throughout your body. You know SDU loves lymph nodes, and this is where you are going to filter lymph, and you can, the T cells can come into contact with the antigen. So, you know, when they were talking about an MSK, if you have an infection here, or if you have a malignancy here, what is the first lymph node that you are most likely going to see presence of this? This is what they're talking about, because you're continually filtering lymph through these lymph nodes, and you're allowing a place for your immune cells to meet up with that so that they can initiate that immune response. So enters via afferent lymph, drains into the cortex via the subcapsular sinuses. Yes, please know that. And then it goes into the trabecular sinuses. So outer cortex, B lymphocytes, paracortex is T lymphocytes, and you have the high endothelial venules. And then you have the medulla. So medullary sinuses drain into efferent lymph vessels. Please know the flow of lymph through the lymph node. That is important. And then of course, outer cortex B lymphocytes, paracortex T lymphocytes. You might be asked where those cells are mostly located. But you'll see here, you know, in contrast with the thymus before it, you don't have the thick tuberculations. You don't have that really intense cortex versus medulla. These are accumulations that you see here. So you see the outer cortex, towards the atop the slide, and then as you get in, you have more of a medulla. Spleen. This filters blood. You have red pulp and you have white pulp. Yes, please know the difference between the two. The biggest thing that you are going to notice to know that you are in the spleen is you have these accumulations with a central artery right here. This is huge, huge, huge to let you know where you are. Because if you see these kind of accumulations, these really basophilic accumulations in any of the other areas, if you don't have the central vessel right here, you're not in the spleen. So you know if you do have it, you're in the spleen. So that's a big identifier there. So red pulp, a network of reticular fibers, filtration of antigen, senile, abnormal red blood cells and platelets. What that means is, you know, you're kind of filtering out the blood, the old, the damaged are going to accumulate here. So endothelial cells are going to line the sinusoids, and then the red blood cells that we don't want get trapped and degraded by macrophages. Remember that macrophages in different areas are going to be called different things. White pulp is accumulation of lymphocytes. So that's T, B cells. So you can see the central artery surrounded by an inner layer of T, layer of B. Yes, please know that if they tell you that a particular type of cell is localized in an area, that's high yield, that's very important, and that is definitely testable. So highlight that. Marginal zones to trap circulating antigen and present it to lymphocytes. Yes, please know that as well. So function, know where different cells are located, where they can be presented with antigen. All of that is important when you're talking about the immune system. But spleen, remember the central artery in these white pulp areas. So also know that this is white pulp, this area right here, that's the white pulp. This is the accumulation of lymphocytes, whereas the red pulp is the network of reticular fibers. Okay, tonsils. You have multiple different tonsils in the area. So you have the pharyngeal tonsil located in the posterior pharyngeal wall. I'm pretty sure you do need to know where these different ones are located and what the big association with it is. So you have an oral part with patches of stratified squamous non-keratinized epithelium, nasal with respiratory epithelium. That makes sense just histologically because the two parts of the areas, that's what it's like there. Palatine tonsils, stratified squamous, non-keratinized. You have the crypts containing desquamated cells besides bacteria, then lingual, posterior aspect of the tongue, can show shallow crypt. So just know where these are located and the basic description of them. Okay, let's try a question.
Sorry. I keep messing it up. After this question that I just gave him the answer to, can you go back 2 slides? I had a question. Lindsey's controlling my screen, so every time I touch my computer, even in the chat, I'm getting timeout. So put your questions to the group, not to me. I can't touch.
Yeah, to the group. Yeah.
I can't touch anything, so.
Yeah, always put your questions in the to everybody, because sometimes somebody can chime in before Brady and I have the chance to chime in. So. But yeah, so this is exactly what I was talking about, DeGeorge syndrome, the 22q11 thing on my first slide. They love to associate DeGeorge with the thymus T lymphocyte. So understand that it will keep coming back to you. And if you learn it now, it's an easy point pretty much every time they test it. So we'll go. Okay, where do you want Brady?
I think one more slide, the second bullet point. Okay, hold on, let me look at it. Right, so in the white pulp, remember red pulp, red for red blood cells, white pulp, white for white blood cells. The central artery, usually, so if you have that artery that comes in, you have this pals layer, they call it. They're the T lymphocytes surrounding the actual artery there, the central artery. And then on the outside of that, then you have the B cells. So it's not super important right now, but that's what they were referring to in that. But I just had a question. So yeah, no, it's all yours.
And remember, all of this is very surface level intro. So the cool thing about SGU is that they keep incorporating it and incorporating it and incorporating it. So by the time, you know, you get to the end of everything, you've seen this so many times in so many different ways that, you know, you understand it more and more and more each time. So you will get another chance to master this stuff. Okay, I'll read some of this because I put a lot of abbreviations here. 30-year-old presents to the ED via EMS from a site of a motor vehicle collision in which she was a restrained driver, traveling 70. She's complaining of pain to her left upper quadrant, left chest wall, left upper extremity, marked left upper quadrant abdominal pain. What's that? Also know that sometimes the pictures they're gonna give you on exams aren't going to be the most colorful, bright, prettiest pictures. And so knowing the defining features of each area is going to be really important if they don't give you one that's obviously spleen, obviously thymus. So just understand that. But all of you guys are getting this right. It's B. So what are we looking at here? Yeah, we're looking at the spleen. It's harder to see in this picture than what we were looking at before. I did that on purpose. But if you see, you have the red pulp and then the white pulp, and then you can kind of see associated with these the central arteries. And then what's A? Yeah, A is going to be more of the diffuse lymph. So you can also see this because it's kind of spread out along a border. So diffuse lymph. Now let's see. This one might be a little hard, but do they have the defining characteristics of any of the other ones? Sometimes it's which one of these is not like the other, or process of elimination. Process of elimination will get you down to 2 answers most of the time. So what's C? I have 1 answer. It's correct. Okay. Yeah, this one's a lymph node. So you are seeing the accumulations here. You don't have that thick trabeculae. You don't have the central arteries. That's what we're looking at. And then D, hopefully this one's obvious. This is a very good identifying picture. You have the very thick trabeculations, and then you have the very defined cortex and medulla. You're probably not going to get a picture as definite as that on your exam, but just understand what these defining characteristics are so that if you get a picture that isn't nice and pretty and colorful, that you can identify what you're looking at. Okay. Brady, it's you. Oh, crap. Sorry. I clicked the wrong thing. I tried to give you control back and I accidentally stopped sharing your screen.
No worries. All right. Cool. Okay. So let's get into the pulmonary stuff. So we'll talk about respiration first. So the typical inspiration when you take when you take a normal breath in, you're going to use your intercostal muscles. So those muscles that are in between the ribs, right? Intercostal. The costals are your ribs, so the ones that are in between. So light breathing, but primarily you're going to use your diaphragm. It almost seems backwards, but the idea is when you contract your diaphragm, you're making a negative pressure inside your thoracic cavity. And with a negative pressure, then air comes in, right? Then when you relax your diaphragm, it kind of spreads back out and it pushes the air out, okay? So your diaphragm is always going to be your principal muscle of respiration. Now, if when you're working out, when you're breathing very heavily, you do actually use some of these muscles. Your sternocleidomastoids run right here, and your scalene muscles in your neck. So when you take a deep breath in, sometimes you have to use those, but ideally you wouldn't. And then with expiration, when you just normally breathe out, it's usually just that recoil effect, right? So you take a breath in, and then the act of your ribs kind of closing back down and the diaphragm kind of relaxing allows that positive pressure to breathe out. So you need to get used to the idea of negative pressure, sort of like a vacuum, bringing air in, and positive pressure pushing out, okay? We're going to use that a lot coming up. And then, of course, accessory muscles, primarily you're going to use your abdominal muscles, right, when you're breathing out. So if you're on the test and you don't know what's going on, just start taking a bunch of deep breaths and figure out what muscles are working. But primarily you use your abdominal muscles when you're breathing heavily to expire or breathe out. This is just a little bit more. They could ask this. These are easy points. Know what goes with what. Quiet breathing versus heavy breathing. Okay. They like this. They always put questions like this on the test. Now, remember, we said diaphragm is your primary muscle. This is going to increase your vertical dimensions, right? Because your diaphragm's below the lungs. So when it contracts, you get that negative pressure. You could breathe in. That's your primary. But also you have these 2 different movements. So when you think of a pump handle movement, you're thinking anterior, the anterior chest kind of lifting out. Now, again, if you're opening the cavity up, you're also making a negative pressure that allows air to come in, right? So that's how that works. But also you have this bucket handle movement that goes side to side. So that's the lateral elevation of the ribs. Same principle. You're opening the cavity, so you're getting a negative pressure inside, so you can breathe in. But again, if they ask which one's primary, it's diaphragm. But these other movements are also important. Okay. Now, you've learned that the visceral pleura, it means organs, right? So your visceral pleura is the pleura that surrounds the organs. Your parietal pleura is the one that tends to be on the outside, okay? So you can see here in this yellowish or orange right here, that's going to be your visceral pleura. This purple right here is going to be your parietal pleura. Now, the thing is that you don't really have pain receptors inside the lungs or inside that visceral pleura. So, but you do have somatic fibers inside the parietal pleura. So if you get some sort of infection in the pleura, in that area outside the lung, in this area here, you can get some rubbing or pleural effusions if you get fluid there. So you may feel pain there. But this visceral pleura is primarily just dull pain versus the parietal pleura. So it's very diagnostic when somebody says they have, you know, just a pain and they can kind of pinpoint it right around the rib cage. It tends to be some sort of inflammation of the parietal pleura, that outside pleura. And they use that diagnostically because it's very different from the inside. Okay, now you can see here that if you compare this lung, right, this area here is the lung, the visceral pleura is going around it. This lung's collapsed compared to this lung. Okay, so for whatever reason, if you have some sort of puncture wound that goes into in between the ribs in the intercostal area, it could cause this lung to collapse. All right, so you need to alleviate that. You may need to pump some of this air out to pull the lung back out. Okay, so I think that's primarily the main part. Mediastinum runs in the middle. That's where your heart's going to be, and this is always called the hilum of the lung. That's that area where the bronchi kind of or the bronchus kind of meets the lung area. Right, so parietal pleura, again, sensitive to pain, somatic innervation. Always one of the things that helps me out is visceral pain is dull, right? You have a stomach ache, it's kind of like this dull pain. You can't really point to it. It's just a kind of all over. Somatic pain is very much like musculoskeletal pain. You could pinpoint it. You could be like, it's literally, with two fingers, I could point to it. So that's kind of tells you the difference in the type of pain fibers there. Okay, and then costal, remember costal means ribs. So the intercostal nerves run with the costal part, and the diaphragmatic part is the phrenic nerve. Remember, if you think about the brachial plexus, the phrenic nerve comes from C3, C4, and C5. So the thing that people use is C3, 4, and 5 keep the diaphragm alive. Okay, and that C3, 4, and 5 make up the phrenic nerve. So if you have some sort of phrenic nerve injury, hint, hint, we have a question coming up, you'd have trouble respirating or breathing. All right, pretty sure we covered this a little bit when we did thorax and musculoskeletal. So they have this vein innervation, okay? This vein artery nerve right here that run inferior to the superior border. Now, we need to use our landmarks here. So if this is the superior rib, this is the inferior rib. This complex, this vein complex is running inferior to the superior rib, okay? So if you need to do some sort of thoracocentesis, you need to stick a needle in there, get air out or fluid out, you need to go lower, okay? You need to go in this region here. So you wanna avoid this because that could cause problems. So remember that this vein complex runs inferior to the superior rib, okay? See that here. I just put this in here for completeness sake. The main thing, I wouldn't get too bogged down with a lot of the vasculature. If anything, just know those anastomoses, right? So if you have some sort of lesion in one, where could the blood go through? When did we talk? We did talk about coarctation of the aorta, I believe, if y'all remember that. So if you have some sort of blockage in the descending aorta, sometimes the blood will be pushed around through these intercostal arteries. Okay, so that's a good example of that. But you could see how these anastomoses attach, but again, it's not super important. Same thing here. The azygous veins are going to help drain the inferior vena cava and go back up into the right heart. But again, this is just kind of here for completeness sake. And then there's lymph drainage too. Remember, everything on the left side and the right lower body goes to the thoracic duct, and the right upper limb goes to the right lymphatic duct, and then they'll drain into the venous system and get back into the bloodstream. All right, embryology. Now, as with embryology, which y'all have learned by now, they don't really test about the process and all those crazy new words you learn. They really test about the problems that can form. So if there is a problem, some sort of diagnostic issue that you come across, you kind of need to know what was the problem that happened. How did it happen embryologically? So let's try this one. And somebody could tell me what this is. So right, so this is a second order question, right? So first thing is always tell me the diagnosis. Yeah, exactly, right? A TEF. Now, let's read it and check it out. So vomiting and choking during feeding, a lot of times they'll say it's the first feeding too, right? It's because, and it'll be projectile vomiting. So the problem here, and if you can see in this picture, they put a little loop down to see if it can get past the point in the esophagus. And you can see that it loops back up. It doesn't go straight down, right? Which means there's no pathway to the esophagus, no direct pathway, which can tell you why the child's vomiting. So it needs to be addressed, right, sooner than later. And then also, which we'll talk about, you get this this large gas bubble here that forms, and that has to do with this fistula that's forming. So incomplete division of the upper foregut. So that's the problem here, and we'll go through it. So this trachea formation, a good keyword for you is this laryngotracheal diverticulum. That's literally what's going to separate the trachea and the larynx from this septum here. So then you have this tracheoesophageal septum, which is where the TEF is actually going to form. Okay, so it separates the trachea and the esophagus, which you need, right? You want air to go one way, you want food to go the other way. Now this is still the development. Okay, so yeah, so you have incomplete development. Obviously, we're still in the foregut, right? Because the foregut goes all the way until past the stomach. So this laryngotracheal groove or the laryngotracheal diverticulum, those are going to be your buzzwords, and those are going to be the problem that forms. Now, the one, and I put a star on this slide, that you need to be primarily worried about is this first one, A. That's what the little child had that we were looking at. So I haven't seen any questions other than A. Right, so there are different variations, as with a lot of things in medicine, but A is going to be the one you want to focus on. So think about this picture. Let's go back and look real quick. You see this little loop right here? Well, it looks like a loop. It's just a thread, right? It's just like a little thread to see if we can get the wire all the way down to the stomach. All right, so let's try. We put it in, we make sure we don't go to the trachea, right? You want to go through the esophagus, but when you put the loop down, it comes back up, right? Problem. Why is the kid vomiting? This is the problem, because when the food or the milk goes down right here, it's got nowhere to go. There's no esophagus there. Okay, so he's going to throw it up. So you need to do something about it. This is surgical intervention, and the kid will probably need a feeding tube until you get him into surgery. So what else? Well, what about that big gas bubble that was there in the stomach? Does that make sense? Well, yeah, sure, because you're going to be breathing a lot of air, and then the air's supposed to go to the lungs, but if it goes through this fistula is an aberrant connection, right? Some sort of tube that forms that's not supposed to be there. So if air goes down the trachea and down this part of the esophagus, then you're going to get a lot of extra gas in the stomach. Okay, so that explains that as well. So two things here: you have a blind-ended pouch, which is what they call this in the esophagus, and this trachea has this fistula that forms where the lower end of the esophagus attaches to the trachea. And that's why you get that gas bubble there, okay? So that laryngotracheal groove, the tracheolaryngeal fistula, tracheoesophageal fistula, and the laryngotracheal groove. These are the kind of things you want to remember. They all correlate with this TEF, okay? Cool. Stages of development, not super highly tested, but probably the most important thing that you learn from respiratory, which we're going to cover in a couple of different variations, embryologically, physiologically, and pathologically. So the main one you want to remember is this canalicular period. Now, the thing is, this is when we start making surfactant, right? My goal, if you learn one thing when we finish this, you're going to understand surfactant, right? Because it's a big deal, because you really can determine whether the fetus is viable based on whether they're able to make surfactant. So usually that 20-week mark is like the mark. You don't want to go any further, any less than that. Ideally, you can get, if the child is premature, you want to get to the 26th week, all right? Because at the 20th week, you start making surfactant. Now, there are medications, which we'll talk about in a little bit, where you can increase surfactant production by giving it to the mother, like glucocorticoids. But that 20th week is when the child will start making surfactant. So if you have a child before that, you're worried about respiratory distress syndrome. The surfactant's kind of going to be what actually keeps the alveoli from collapsing. The alveoli collapse, you can't get proper blood exchange from the alveoli to the blood, right? So That's kind of our landmark, that 20 to 26 week period. Okay, so keep in mind this canalicular period is when you're going to start making surfactant. All right, try this one. Right, very good. So these are the type 2 pneumocytes. You want to remember those type 2 pneumocytes are going to be what produce surfactant. Now, as you would expect, this barrier that you see here is 1 cell thick, right? And these are going to be our type 1 pneumocytes. They're going to produce the barrier that separates the blood from the alveoli, right? Which you would expect to be very thin because you want oxygen to be able to go from alveoli to blood and carbon dioxide to go from blood back to the alveoli so you could breathe it out. Now, these larger cells that kind of cluster here are going to be our type 2 pneumocytes. Again, start making them at week 20. You kind of finished making it. The lungs are fully developed by week 26. So that's kind of our landmarks there for premature babies. But you could kind of see they have more like an eosinophilic or a lighter staining to their cytoplasm, you know, and they're a little bit bigger than these type 1 pneumocytes. Okay, so good. Right, again, same thing. You can see larger these type 2 pneumocytes. I think histology here is fair game. So make sure you know those. And then these lining cells are going to be more of your type 1s. Okay, you can see that larger one, type 2. All right, so kind of what we were talking about. Around week 20, we're going to start 22 to 26. You're kind of at your survival range. So 26, if you can keep the fetus with the mother until week 26, you know, the longer the better, obviously, but 26 is a good mark because you could finish making surfactant by that point. If not, if you know there's a medical emergency, you got to do it sooner. Maybe give the mom glucocorticoids because that has a process of making extra surfactant. You don't need to know why, but it is good to know that that could be used, right, to help prevent respiratory distress syndrome. Okay, and then the lung development. So these are kind of how it works. Remember when we talked about the cardiac, the embryology, our whole goal was to bypass when we use those, the foramen ovale and the ductus arteriosus, we were bypassing the right heart, the lungs, right? We were using the blood from the right heart to go to the left heart instead of going to the lungs. And the whole point is that you needed the lungs to develop. You needed to eventually make surfactant, but you also needed the lungs and the musculature of the lungs and the vasculature of the lungs to develop. And that process involves the fluid. The child is going to breathe in amniotic fluid. Some of it will go through the esophagus, but some actually gets to the lungs. And the process of it getting to the lungs helps to develop. Now, one of the problems, as you can imagine, is if you have a decreased amount of amniotic fluid, oligo meaning less, hydramnios, then the child's not going to be able to have enough fluid to breathe in. Okay. Now, if the child doesn't have enough fluid to breathe in and that fluid is involved in lung development, then maybe you're going to get some sort of pulmonary hypoplasia. All right. Because the lungs didn't have the fluid to keep breathing in to help properly develop the lungs. Okay. So hypoplasia means it's just not fully developed. Okay. So keep that in mind. All right, so the different hernias that can form, the primary one you want to worry about is this congenital diaphragmatic hernia, okay? The big buzzword, let me see, I didn't put a star on it, but big buzzword you need to know, pleural peritoneal membrane. So if that doesn't develop properly, that kind of makes a full layer of the diaphragm. So if it doesn't develop primarily, then you can have the guts or the intestines kind of come up through into the thoracic cavity. Now there are different ones, but when we're talking about lungs here, not the GI tract. So in regards to lungs, this diaphragmatic hernia is going to be what's important. And this is why, because if you have that pleuroperitoneal membrane that doesn't form right about here, right on it, or you could see it here in this black area, then the GI tract is going to go up into the thoracic cavity. And how do you think the baby's lungs are going to develop? Well, you can't really expand, right? You can't bring that fluid in. And if that's the case, you're also going to get this pulmonary hypoplasia. Look at this. You could see this. All of those little gas bubbles there are the GI tract. Okay, so this membrane didn't form, and the GI tract is up in the thorax. All right, so if the baby can't properly take in all that fluid, then the lungs aren't going to develop, and that's a problem. Okay, so similar to oligohydramnios, but this is more of a functional deficiency because it's not necessarily that there's lack of fluid. It's that you can't properly breathe in. You can't make that negative pressure to breathe in the fluid because the GI tract is kind of taking up space. Now, there's also the eventration of the diaphragm. Now, you don't get a complete separation. The pleuroperitoneal membrane does form, but you don't get the pleuroperitoneal musculature. It should say that. Failure, okay, yeah. So it's actually the pleuroperitoneal muscle, right? That's what doesn't form. So the muscle, so you can see here, this membrane's still there, but you don't have the muscle of the diaphragm. So you don't actually get a true herniation through, but that muscle kind of holds the GI tract down. So if the muscle's not there, the GI tract could kind of push up. Now, again, the membrane is still there, so it's not a true hernia, but this eventration happens. Now, what they say is this paradoxical respirations, because when the baby breathes out, the GI tract will come up, right? So you would expect when the baby breathes out, the thorax should go down, but because when the baby's breathing out, the guts come up, you would see it actually bulge out. Hope that makes sense, right? You imagine when you're breathing out, your chest should kind of compress down, but at the point when you're breathing out, the GI tract is able to push up. So you would see this paradoxical, meaning it's not the right direction. Okay, but they may not ask you about that, but they could ask you about the fact that there's no musculature there. All right, and let's see. Right, so I guess, well, you could kind of see, I don't know why I put this in here. Oh, all right, no, this is just to reiterate the fact that this is this gas bubble that you see there. You kind of see the heart coming down here, and it's still a child, so the thorax is properly lengthened, but you could see that you see a little bit of gas bubbles there, but with the tracheoesophageal fistula, you would expect a lot more, right? So it would be much darker there because on x-rays, gas shows up darker. All right, clinical anatomy. Let's see. Now, just some definitions here. Very importantly, this costodiaphragmatic recess, okay? This is that little point at this, right? So the parietal pleura will go around the cavity. The visceral pleura is going to go around the lungs, okay? So there is this little gap here that if there's some sort of problem, fluid can develop. Now, why does fluid develop down there? Because it's the most dependent place gravity-wise if you're standing up. So sometimes you get fluid there and that could cause a problem. It could lead to some sort of infection, or an infection could lead to this accumulation. Regardless, you don't want to have fluid there. Now, the thing I want to point out is here, if we look at this x-ray, right, so the left side of the patient, right side of the patient, what you should see is this sharp point. That's what the doctor that was making the slides was trying to get at here. This sharp point meaning you don't see fluid. What they say here is this is blunting of the diaphragmatic recess, okay? If you would expect to see a point come down here, but you see it's blunted, you can't appreciate the point, and that means there's fluid there. So you'll probably have to do some sort of thoracocentesis where you stick a needle in right through here and get that fluid out, okay? All right, now, if you're gonna do a thoracocentesis, these are the areas you need to be aware of. Now, the point is you don't want to pierce into the pleura and anywhere where the lung is. You want to go lower than that so you can get into the pleura without affecting the lungs. Now, since fluid's going to go to the lowest place, they like to test gel on the fact that if you do it paravertebrally, you would go around T11, right? Between T10 and T12. Truthfully, in the ER or wherever they do this, they usually go mid-axillary, because you can imagine, putting a needle in the mid-axillary line is much less intrusive than going right beside the vertebrae, right? There's a lot less musculature there. So the key thing to focus on here is they're asking you, where are you doing it? Mid-clavicular right here, mid-axillary right along the lateral side, or paravertebral. So as you go from front to back, the lungs will go a little bit lower, as you can see in this guy here. So just remember, from front to back, front side back, you go 6 to 8, 8 to 10, 10 to 12. Okay. Pneumothorax, spontaneous pneumothorax are pretty weird. They usually happen in growing kids, like teenagers. They talk about these pleural blebs that rupture, and then you actually get these air pockets that form pneumo, meaning air in the thorax. The ones you need to be concerned about now are these traumatic ones. So they'll have some sort of blunt force trauma, or some sort of injury that causes a suctioning effect. Now, the problem, let me see if I better, look at this slide. And this traumatic pneumothorax is usually considered a tension pneumothorax. So the problem is that you've initiated some sort of pathway for air to go. Now, the thing is, when it's a tension pneumothorax, the air can get in, but then it closes off and the air can't get out. So every time you take a deep breath in, a little bit of air can get in, but there's no way for it to get out. So this is a medical emergency. They usually fix these with chest tubes in the ER. So you can imagine, if you keep introducing air into this cavity, you're going to collapse this lung, and you're going to push all the organs to the other side. Okay, so one of the things that they like to test on is not only this mediastinal shift, which is the mediastinum being the middle part shifting, but you would expect, because it's a tension pneumothorax, for the trachea to deviate away from the injury. Okay, they like that. They say the trachea deviates to, as you can see in this patient, to the left. So where's the injury? Well, it's to the right. Yeah, you would consider both these non-tension and tension to be traumatic. Yeah, spontaneous usually is a different category, but non-tension usually means that the air can get in and get back out. But by far the most common is this tension pneumothorax. So
just pay attention to presence or absence of mediastinal shift. That's the biggest thing here to take away. And pneumothorax can happen for various different reasons, but it's what happens with the pneumothorax that's really important here.
Right, so you would expect the mediastinum to shift away from the injury, right? Because if you're putting air this way and you're putting pressure this way, everything's going to go the opposite direction, and you're going to get tracheal deviation away, right? So again, if you're looking at an X-ray, what would you expect the trachea to look like? It should look dark. I think I might have a question, but yeah, let's look at this. Well, it's not a question, but now, if you're just looking at this, what in the world are we looking at? So you expect these little lung markings, right? Those come off the hilum. When you get to pathology, you'll see some pneumonias make this a lot worse. But you would expect to see this lung marking. So on the right side of the chest, you see lung markings. Okay, cool. What about on this side? Why is it so dark? Well, look, the lungs completely collapsed right here. That's why you don't see any markings. This dark area is empty space. It's air buildup in the pleural sac, okay? So you can see that now. It's a little bit hard to appreciate, but you can kind of see the trachea here. You see the tracheal rings and then the buildup of air, but it should go straight down. But you can see that the trachea is deviating away and the heart is on the opposite side. I don't even know if this patient could even make it at this point. This is very bad if it's not corrected immediately. Look, the heart's all the way over here. So everything's getting pushed to the patient's right because you have an injury on the left, okay? Sorry. According to the van, yeah. So if the van runs inferior to the superior rib. So if you were to do some sort of chest tube or thoracocentesis, you would put the needle superior to the inferior rib. Okay. It's hard for me to keep up with the chat, but I'll do my best. All right, so let's say this is our superior rib. This is our inferior rib. If you have the van running right here, the van runs inferior to the superior rib. So if you were to do a thoracocentesis, you would want to go superior to the inferior rib, okay? So this is where you would put the needle to avoid this, this bundle up here. Okay, so just for clarification, this cartoon is opposite of this, right? The injury is initiated on the patient's right here, where the injury is over here on the left. But if they were to give you this picture, the first thing you want to look for are these lung markings. You don't see them because the lung is completely collapsed. Okay. Yeah, so this one's even better. Look at this. You can see the trachea here, this light area, because it's air. Look how much it's deviating. Look at this collapsed lung and all this air. So this is similar to the last one we looked at. If you were to look at an axial cut, you could see that here, all this air in the pleural space. It's pushing the lungs. It's collapsing the lung because of all this air that was introduced. Yeah, you could see the injury right there, straight through the musculature. All right, so this is from first aid. You kind of go through this, but again, if they're going to test you, they're going to ask you all about the traumatic one. All right, so just completeness sake, this is more of a pathology-based question, but these Pancoast tumors, they kind of happen at the apex of the lung. So they kind of circled all these, but primarily they happen up here. The problem is sometimes it'll press on the sympathetic chain, which runs along the vertebrae. Now, if it does press on that, you get what's called Horner syndrome. So first off, let's do this. So it can actually compress the right recurrent laryngeal nerve. And as you could see here, that the right or the recurrent laryngeal nerve is going to innervates the larynx. So if you have some sort of lesion there, it can end up with hoarseness, right? But you can also get what's called thoracic outlet syndrome, where it presses on the vasculature. And if it does that, if it ends up compressing the vasculature, you're going to get problems distal to that. So problems in the hand. So this is this thoracic outlet syndrome, where you can get cyanosis and paresthesias, primarily due to lack of blood flow to the upper extremity. I think, yeah, there's Horner syndrome. Okay, now if it does press on the sympathetic chain, right, this Pancoast tumor up here, you're going to get, so you're compressing the sympathetic, so you're going to get unopposed parasympathetics. Okay, hope that makes sense. Which means you have this triad, ptosis, meaning the upper lid is going to be a little bit, it's going to droop a little. And you'll get to that when you do neuro, but part of the sympathetics help to elevate the eye, one of the muscles in the eye. So you get this ptosis. Anhidrosis means you're not sweating, right? Remember, sympathetics allow sweat. So if it's a if you compress the sympathetics, then you get unopposed parasympathetics, then you're going to get anhidrosis. And you get meiosis, which is pupillary constriction. This is a little early for you guys, but this is fair game because they really like Horner syndrome because it kind of incorporates a lot of different areas. So here's a good way to remember: meiosis meaning pupil constriction versus mydriasis meaning pupil dilation. Meiosis is a smaller word, so it means the pupil is smaller. Mydriasis is a bigger word, so it means the pupil is bigger. So when you think of Horner syndrome, you're knocking out the sympathetics, you're compressing the sympathetics, so you get these unopposed parasympathetics. Remember, the autonomic system is always a balance. So if you knock out sympathetics, you're going to end up with this triad. They love triads, so there you go. Now, when we divide the lungs up, on the right side, you're going to get 3 lobes, but remember the heart kind of dives off to the left. So you're only going to get 2 lobes over there. It's easy to remember because the heart kind of takes up the space that that third lobe does on the right. So you get this, I think I have, yeah, here we go. This oblique fissure here that happens on both, but in the right heart, you also get this horizontal fissure. So you can see that here. But in the left lobe, you just have this oblique fissure, and the heart kind of takes up the space there. I have a better picture of it coming up, but if they would ask you this and they showed you this, if they divided into 3, then it has to be the right side, right? This one, you could kind of appreciate this oblique fissure here. That has to be the left. Okay, so just keep that in mind. Yeah, this is the one I wanted to show you. Now, the thing is, what if you had a knife wound to the back on the right side, on the lower aspect, say like T10? What's interesting is that this middle lobe kind of wedges in there on the front side. So even if you had a knife wound to the back on the right side, you would get the lower lobe because of the way the middle lobe kind of fits in here, okay, through like the 4th and 6th intercostal space. So just keep that in mind, the architecture there. All right, they love this question. Try this. All right, good. So what if it gets past that point? Yeah, right, lower lobe. Very good. Yeah, sweet. So yeah, right bronchus. Yeah, you can aspirate, right. Very good. Sorry. Okay. And you can kind of see that here. So the right bronchus that goes down to the right lower lobes. Yeah, so it's going to get cut in the right bronchus. Sorry, I was reading the chat as I was talking. It goes to the right bronchus and it goes to the right lower lobe. That's the most vertical point of transit. So if you swallow, the child swallows a toy or whatever, it's going to go to the right lower lobe. Sorry about that. And you can see that here, right? Child swallows something. You can see the coin is stuck here in the esophagus, or sorry, in the trachea. Right lower lobe. So definitely know that. This is important. I remember getting tripped up on these. So the best way to do it is correlate the area, like this larger word, with the smaller word. So if they ask you what's around the hilum, just know that that's bronchopulmonary, and tracheobronchial is going to be around the carina, which is that middle point. And then paratracheobronchiomediastinal and all the way through to the systemic venous system. But I think this is fair game, this lymphatic drainage going from the lungs all the way up. All right, try this one. All right, so anytime, you want to keep in mind that anytime we're talking about pneumonia, pneumonia is always consolidation, okay? Lobar pneumonia tends to be bacterial, and that makes sense because you give antibiotics for bacteria. But if we look at this, you can appreciate this consolidation here, right? All of this buildup. So that would be what's characteristic of pneumonia. And we discussed this pleural effusion, this blunting process, pleura, right? Meaning that in that pleural space, and the effusion meaning fluid buildup. So you get this blunting. Remember, you should see pointy edges down here at that cosodiaphragmatic recess. So if it's blunted, it's pleural effusion. And pulmonary edema is a collection of fluid in the alveoli. So typically that correlates with pneumonia. So any sort of consolidation of fluid buildup or pus or any sort of inflammatory reaction, you could kind of see. So you could appreciate that this left lung is worse than the right. Right lung looks bad too, but you could see all this extra consolidation here, and that would correlate to pneumonia. All right, histology. Let's try this one. All right. So a little tricky, but the point is that at this point, when we're looking at this interalveolar septum, you need elastic fibers. And so what that allows is that, remember, the elastic fibers kind of stretch. They're kind of like a rubber band. So this allows the alveoli to open. And when you breathe out, it allows them to push the air out. So this guy's in respiratory distress. If I had a guess, I'd say he's probably a smoker, because that the smoke inhalation can lead to destruction of the elastic fibers. Okay, so that's why they end up with emphysema and stuff like that, which we'll get to in a little bit. But yeah, those elastic fibers can be super important in this area. All right. Oh, this is Lindsey stuff. Lindsey, you're up.
Okay, requesting access again. Wait, did it request it? Request remote control request. Okay, cool. Okay, histo, very high yield, but they, you know, you can kind of pick out what they're going to focus on. So we're going to go step by step. We're starting at the top and going down the respiratory system. Is this my first slide on here? I think it's the first slide I have on here. Yeah. So trachea overview. You have respiratory epithelium. Please know where respiratory. Oh my God, respiratory epithelium starts and ends. Oh my goodness. Okay. Submucosa with seromucous glands. This is going to be helpful for identification. So when you see this right image here, you can see those submucosal glands. This can help you identify, okay, this is where I am. I'm in the trachea. There's this thick layer in the submucosa. Okay, I'm good. I know where I am. It has a cartilaginous layer with the thick hyaline cartilage. This is for support and stability. You'll notice at the back, you're going to have that layer where there is, it looks a little different. This is trachealis smooth muscle. This is the gap in that cartilaginous ring, which is adjacent to the esophagus. So you know, if you are asked an association, a relationship question, you know where the esophagus is located with respect to the trachea because of this trachealis smooth muscle. This picture is very easy to see, the one where you can see the ring. However, they may not give that to you on the exam. So again, make sure that you know how to identify at each individual location. In this picture, in the far right, you can see the glands in the submucosal area, but you can also see this trachealis muscle in that gap in that cartilaginous ring. So make sure you can identify that no matter which view they are giving you. Okay, moving down, we are getting to the bronchi. So you have primary, main, and then you keep going down and it branches. You can see here, it does have a muscular layer, which is regulating the airway. It has a cartilaginous layer. Now here you're going to see the cartilaginous plates. This is very different from that really nice ring in the trachea that has the, you know, the big, thick, stabilizing cartilaginous ring. And so notice here that you are going to see cartilaginous plates. And then, okay, yeah, that's what I said. So you can see on here, how do I wonder, no, that's not what I wanted. When I'm controlling his screen, I don't know if I can use like a laser pointer or something. If anybody is like a tech person, you have a suggestion, but that's how you tell the difference. Then moving down, talking about specifically the respiratory epithelium, conducting part of the respiratory pathway. Annotate.
Sorry, Lindsey, can you right click and just select the laser pointer from?
No.
And sorry, I had a question. I can't type in the chat while she's doing this, but yeah, we'll take a break in a little bit.
Yeah, no, if I try to right click, View options. If I annotate, I mean, I can annotate mouse. Oh, can you all see this? No. I don't know. Okay, y'all can see my mouse. Cool. So you see this, the CP, the cartilaginous plates, this is what you're going to look for if you see, if you have this. The biggest thing, this is just, wait, yeah, conducting. So it's just passage of air through the system. Respiratory epithelium, conducting part. Why do you have respiratory epithelium in the conducting part of the pathway? Well, because you are moving air from one location to the other, but you are also having in this air, you have particulate matter. And so these ciliated cells are going to be able to whisk up anything that shouldn't be there. And they call it the mucociliary escalator. And so in the conducting part of this pathway, where you are getting a lot of that matter, you have these cilia that can whisk up stuff that should not get to the terminal areas where it can cause issues. So that's why this is very important in the conducting part of the respiratory system. So within the respiratory cells, what do we have? We already talked about the ciliated columnar cells. The biggest thing here, they love to talk about this, is Cartagener syndrome. This is primary ciliary dyskinesis. This is what this is located in the cilia. That it has, I forget which motor protein is messed up here, but the motor protein is messed up. You don't have that mucociliary escalator. You don't have that beating. And so you're not getting the expulsion of mucus from the system. Dining, thank you. You don't have the expulsion of mucus from the system or particulate matter. And so it builds up. And so with Cartagener syndrome, you can have a lot of respiratory issues because of that. You have the mucus cells. So these are secreting the mucus. So short, blunted microvilli, small granules, which are Kolchitsky cells. I'm pretty sure they use the word Kolchitsky cells if they tested it. And so bifurcation of primary bronchi. And then I don't know if this clinical correlate was important in term 1, but they put it there. And so if they put it there, they think it's important. So affects small cell lung carcinoma of the lung. Small cell carcinoma, that's a really common place, that bifurcation of the primary bronchi. That's where you're going to find a lot of those cancers. But biggest thing, Cartagener. Star it, highlight it, make sure you understand that, and then know what the respiratory epithelium is, the ciliated columnar cells, and then where it starts and where it ends. Okay, talking about smoking and chronic bronchitis. I starred this on the side here because these are the 3 hallmarks of this area. It's the thickened basement membrane, hypertrophy of the smooth muscle, and the increase of the glands. What this does, it decreases luminal space, both because of the physical thinning, and because you have increase of the glands. If you increase glands, you have increased mucus, which is going to further impede that lumen. So thickened lumen plus extra mucus, bad stuff. So chronic bronchitis associated with smoking, inhalation of toxic fumes, exposure to air pollution, essentially any irritant. So what is actually happening, why you're getting this reaction, the thickened basement membrane and the hypertrophy, it's a response to an injurious agent. And so it's basically saying, okay, I need to protect myself. I need to protect myself. These are compensatory mechanisms that are used to protect yourself. But remember, when we were talking in cardio, compensatory mechanisms aren't good in the long run. And so on exam, you're going to have wheezing and cyanosis. That's because it is an obstructive disorder. So you can't really get passage of air through it. So these are the blue borders, blue bloaters. So you're not getting air in. The wheezing, that is caused by, that's the sound of the air going through a narrowed pathway. Cyanosis, because you're not getting the air in. So chronic inflammation, inflammatory changes, metaplasia, this is what I was talking about. It is a reaction to the injurious agent. And then metaplasia, we all know if they talk about metaplasia, they might test it because that is kind of the first step to dysplasia, which is you know, on the road to cancer. So that is the importance here. But those three things that are associated with it, you need to know, and then know that chronic bronchitis is one of those blue bloaters. It is an obstructive disease. Okay, clinical note, squamous metaplasia. Again, metaplasia, they talk about this. It's really important because metaplasia is that response that your cells have to an injurious agent. They're like, okay, we need to do something to protect ourselves. So they're going to change. And metaplasia, you can change back if you remove the injurious agent, but if you don't, it can lead to dysplasia, then cancer. That's the big thing here. Know it exists. If they talk about a cell change, they talk about removing the injurious agent and it goes back to normal, it's metaplasia. Bronchiole, so we're getting further down, we're getting smaller. So your epithelium is the ciliated pseudostratified columnar. Now this is important with goblet cells in the larger bronchioles and ciliated cuboidal with secretory and the terminal and respiratory bronchioles. Please make sure you understand where these cells are located. It can be used to identify where you are. So if they say that there are a large amount of goblet cells, you know you're in the larger bronchioles. But if they're talking about more club cells, more ciliated cuboidal, then you're in terminal and respiratory. So you know that respiratory epithelium, the ciliated columnar, as you get down, 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 cells get smaller, smaller, smaller. That makes sense, you know, because once you get further down, you're transitioning from a conducting system to the actual respiratory system where you are getting exchange of particles. And so the cells need to get smaller and the function changes. You get a difference in the cells making up the area. So think about why that's important, why you have different cells in the area, the characteristics of those cells, and hopefully it can make sense. So if they talk about a different cell type in an area, you can pinpoint, I know where I am in the respiratory system. Smooth muscle replaces cartilage. This makes sense because cartilage you need up in the trachea and the bronchioles, main bronchioles, because you need stability there. You don't want your airway to collapse on yourself. That is bad. But when you get further down the system, you don't want that stability because you want the ability to expand and contract with air movement into those areas. And so you are going to get more smooth muscle. You're controlling the diameter a little more, which is very important in these areas for a lot of different reasons, which we'll talk about later, but Brady will get into, but you want to have a little more flexibility once you get to the terminal areas. Again, make sure you understand terminal bronchial versus respiratory bronchial. Terminal bronchial you see there, it's very well demarcated. There's a lot of smooth muscle there. It's very thin, but when you get down to the respiratory bronchioles, it's thinning out more and more and more, and you are actually starting to see alveoli there. So in this picture on the bottom, you see B for bronchial, terminal, so you're seeing terminal bronchial here, then you're getting more into the respiratory bronchial, but please be able to tell where you are, both by the histological slide and by the descriptions of where you are. Bronchus or bronchiole, please say left or right, which image in the chat. Yeah, the right one is going to, yeah. So the right one is going to be your bronchus is going to be more up high into the system. You know this because you're seeing, you have some smooth muscle here, but you also see these cartilaginous plates. This is the big thing. Remember, you have these cartilaginous plates. You do not have the trachealis muscle, so you know automatically you're not in the trachea, but you do have some cartilage there. So you're like, okay, I haven't really gone into the lungs yet because I still have that cartilage, but I don't have the trachealis muscle, so it must mean I'm in the bronchus, the main bronchi right there. Now, if you look on the picture on the left, you don't have cartilage anymore. So it's pretty thick, it's pretty substantial. You see some smooth muscle there. So you're like, okay, so I know I'm not in the terminal bronchial right now. I know I'm not in the respiratory bronchial, but I don't see any cartilage. So where am I? You're now in the bronchioles because the cartilage is being replaced with the smooth muscle, but it hasn't really thinned out yet. So you're seeing these columnar cells, the ciliated columnar cells here. So does that make sense? Can you tell the difference between these two? So starting at the top, trachea, you see the thick cartilage of the trachealis muscle. When you go to the bronchi, you are no longer seeing that trachealis muscle. You're seeing some smooth muscle, but the biggest thing are the cartilaginous plates. As you're transitioning down to the bronchioles, you're losing the cartilage, you're gaining more smooth muscle. The cells are becoming more cuboidal versus columnar. So we good with that? Okay, so also presence of glands, cartilaginous plates, smooth muscle replaces cartilage. Can you say that slower? Yes, I speak really quickly, I apologize. So starting at the very top with the trachea, you are going to have that thick cartilage ring that is interrupted by the trachealis muscle. That's how you know you are in the trachea. You also have the presence of glands in the submucosa, if you are looking at it in the other slide. When you transition down into the bronchus, main bronchi, you now you have the cartilaginous plates surrounding the entire area. So you're losing that trachealis muscle. You have the cartilaginous plates that are broken up around it. You still have the presence of glands. You still have smooth muscle, but the biggest thing you have those cartilaginous plates. As you're moving down, you're losing the cartilage and you're gaining more smooth muscle. The cells are getting more cuboidal. And of course, you are getting more mucus cells. And as you are going down, the cells kind of transition to different ones. Okay. Another clinical note, bronchial asthma, it's inflammatory airway disease. Again, anytime you narrow the lumen, you're going to have an issue. So pathophysiology, you have an airway obstruction. We talked about some of these: increased mucus, increased smooth muscle, bronchiolar wall inflammation. This can be triggered, again, if you have smoke or something around, you can trigger an asthmatic attack, but treated with albuterol beta-2 agonist, they might ask you that there because that's a cumulative question that is directly associated with the information you're learning now. So hint, hint, if you have a cumulative piece of information that they reference in your what you're doing right now, they're probably going to bring that back in because that's a really good way to incorporate the information. So star that, just so you know. Again, we talked about this thickening, hypertrophy of the smooth muscle layer when we talked about the bronchitis. You also get that plugging of the airway of cell debris and mucus because you're having the increased mucus with the increased number of glands. Respiratory division. So now we are getting further. We are going alveolar sacs and alveoli. So now we are actually talking about exchange of air between the outside world and your system. So in the alveoli, there are multiple types of cells. You have macrophages, type 1 cells, type 2 pneumocytes. Macrophages are super, super, super important here because even though we try to decrease the amount of particulate matter that gets to the terminal alveoli, it still happens. So you still have the alveolar macrophages there that are there to clean anything up that gets past the conducting system. So alveolar macrophages are called dust cells. You can see this in the actual lumen here. So notice that. I think we talked about type 2 and type 1. Yeah, type 2 and type 1. So now we have the air-blood barrier, thin portion and thick portion. Thin portion, of course, this makes sense because if you want to have air exchange, you don't want a very thick barrier between the two. So this is the most effective air barrier. You're getting the surfactant, type 1 pneumocytes. You have the fused basal lamina and capillary endothelium. Please know what the barrier is made up of. They will most likely test you on that. And then thick, you have the surfactant, type 1s, basal lamina, connective tissue, basal lamina, the capillary endothelium, endothelial cells. We're going to talk about how you can differentiate between the type 1 and type 2. Pop quiz, which one of them, you should know this, is the surfactant? Yeah, type 2. And which one of them are the replicative ones that can replenish your cells in the area? Replicative is going to be the mitotic one, so they're going to replenish the cell population in that area. We'll talk about it in a sec because we're getting some back and forth. But another clinical correlate, obstructive COPD, chronic obstructive pulmonary disease. This along with your, yeah, every time I move, it hurts really bad. This and bronchitis, they're both under this umbrella. COPD is an umbrella of diseases. So you think COPD, it's not just one thing, it's a lot of things under this umbrella. It's basically an obstruction. So we talked about it with bronchitis. It's anything that's going to cause obstruction of the airway. Emphysema is just one of those examples. Chronic bronchitis is another example we talked about. So it's characterized by the enlargement of respiratory spaces affecting airways distal to the terminal bronchioles. I underlined it. I think that's important. I don't remember that being too big of a thing. The biggest thing is this serum alpha-1 antitrypsin and its correlate the antitrypsin deficiency. So basically the thing is you have elastase in your alveoli, right? Because you do need the ability to control the area in the alveoli. So you have this connectivity, you have this elastase in there. Well, you also have neutrophils that are going to release elastase, which can break down the elastin. And so you're effectively destroying the area with which you can do oxygen transfer across the cells. So if you have a lot of neutrophils in the area and you have this elastase, you're breaking it down, you're essentially destroying your lungs because of this elastase. Well, you have something to kind of protect against that. And this is the alpha-1 antitrypsin. So you're going to have neutrophils in the area, remember, because you are going to have things that get down there that shouldn't be down there. You're going to have an immune reaction. You get the neutrophils. And if you have an appropriate level of the alpha-1 antitrypsin, you'll be fine, right? Because it's going to counter the elastase activity. And so even if you are getting a little bit elastase activity, you're getting the destruction, you still have that counterbalance there of your personal enzyme to make sure that you don't have the, enough destruction to actually permanently dilate the airways and get emphysema. But for those who have an alpha-1 antitrypsin deficiency, they don't have the ability to counter the elastase that the neutrophils are producing. Then you get continual breakdown of the elastic fibers and you get permanent dilation of the airways. That was a long-winded way of explaining that.
Okay. Let me see. So wait, let me just answer this question. So yeah, the type 1 cells are smaller and they do the lining on H&E stain. Type 2 cells are a little bit larger nucleus. And they have like a eosinophil. Somebody just asked. Yeah, they have an eosinophil.
I thought I had a slide in there. That's why I didn't talk about it on the particulars, because I thought I had another slide that talked about T1, type 1 versus type 2, and then how to differentiate. You probably have one. That's probably what I'm remembering.
Yeah, okay.
Because there is a slide that tells you what the difference between the two and how to tell the difference. So it's probably in one of your slides. That's probably, because that's why I didn't talk about it, because I was like, I know there's a slide.
No worries. Okay.
Well, you're gonna know. You're gonna know. We're gonna tell you.
All right, we'll take a 5-minute break real quick. Give y'all a break, and then we'll come back and we'll keep going. All right, so 5 minutes. All right, y'all ready? Can we do this? Let's do this. My friends just got out of quarantine and they're going to the beach, so we're gonna do this. All right, whatever. Because I love you guys. We love you guys. All right, so lung function tests and stuff. So some of these aren't super important. We'll get to the more important equations. But honestly, our test, as much as people were stressing the equations, they weren't highly tested. Again, maybe just because we can't use scratch paper and stuff. So they're not going to give you complicated equations. They keep everything theoretical, but this is just this blood gas barrier. Obviously, the thing you need to worry about is this thickness. The thicker it is, the harder it is for things to diffuse across, and then the surface area available, which has to do with surfactant, which we're going to get to in a little bit. We've done this at length, right? Type 1 pneumocytes and type 2. Those type 2s are going to be the ones that make the surfactant, that keep that the alveoli open. Now you can see here, it'll stabilize the size, keep it from collapsing, excuse me, increases compliance, meaning allow it to expand, and it'll also keep the lungs dry, right? So you don't want any sort of consolidation, such as pneumonia, right? So the primary reason you use it is to decrease surface tension. And that's what we're going to discuss in a second. This is going to be one of those words. I try not to remember words like this. It's actually abbreviated DPPT, or maybe no, it's DPPC. Sorry. Yeah. So because if you remember DPPC, then and you see this word, it kind of works out. I don't know if that works for you. It's kind of a trick way of doing it that you don't have to try to remember these crazy long words. But yeah. Okay, so I do like this slide a lot because it kind of tells you where everything ends. So you could answer a lot of those histology type questions, but it would make sense that the conducting zone, the zone where the air is just going to go through, would have cartilage. They're larger cavities, or they have larger lumens that and higher pressure. So you're going to want a lot of structure there. Such as cartilage. But when you get down to the respiratory zone, you lose a lot of stuff, such as these goblet cells. Remember that those are going to produce mucus. So you're going to worry about debris and stuff up in the conducting zones that the goblet cells can deal with, smoke inhalation and stuff. And then also the cilia goes down through the respiratory bronchioles. Those are going to cause, it's called the mucociliary escalator, right? So it's this unidirectional flow. The cilia move up and it pushes all of the debris upwards. Okay, cartilage again into the conducting zone. Then you're going to have smooth muscle all the way down to the ducts. Obviously, you don't want muscle in the actual alveoli because you want it, the barrier to be as small as possible so you can get air conduction across. And then elastic fibers are going to be necessary to keep, because when the alveoli expand and you need to exhale, they're going to help to collapse. So again, I like this slide because you do need to know kind of where everything is. Okay. I like this slide so much, I included it from first aid. So there you go. Now, very important, we're going to talk about these obstructive diseases versus restrictive diseases. So you're going to branch these completely apart. There's not a lot of overlap. So obstructive diseases tend to be problems getting air out. Okay. So things such as COPD, they're able to breathe in, but they can't breathe out. Problems with the respiratory zone tends to be problem with getting air in. So you get like pulmonary fibrosis. So if the lower aspect of the lungs are fibrotic, then it can't expand properly, right? You don't get a lot of compliance, so therefore you can't get air in. So keep conducting with the inability to get air out, such as asthma, COPD, bronchitis, stuff like that. And then the respiratory problem, you're typically caused by fibrosis. A lot of these diseases you will talk about later, but they all pretty much involve fibrosis or decreased compliance. Again, compliance is your ability to expand. Or are you compliant to the air coming in, right? So fibrotic problems will be that. All right, now, so bronchitis is going to fall under COPD. It's going to fall under obstructive lung disease. Chronic bronchitis is primarily, for all intents and purposes, all thing you need to worry about right now is cigarette smoking. Now, when you think of chronic bronchitis, you're thinking increased mucus production. The thing is, bronchitis and emphysema tend to go together because they're both caused by smoking. But for right now, we'll talk about bronchitis. So anytime you get increased mucus gland secretion, a lot of coughing and stuff like that, that's going to be the bronchitis. You get the cilia that usually sweep debris up also get destroyed. So you get a lot of glandular hypertrophy and stuff like that. So you see that with bronchitis. This is more of a important equation. It's it's a component of Boyle's law. If you assume temperature is constant throughout, you can use this. But we're going to use this in theoretical purposes, right? Because these pressure and volume are inversely proportional. And you can see that here. If you increase the pressure here, you're decreasing the volume, right? Cool. So if you're decreasing the pressure comparatively to this one, you're increasing the volume. So that's the principle between this Boyle's law. Okay. Yeah, that's Boyle's law. I guess Charles involved the temperature, but we assume temperature is constant throughout, so we're not going to worry about that. All right, now we're going to talk about this concept of this negative pressure. So what you need to keep in mind, if you can see my cursor, the diaphragm is underneath here. So if the diaphragm contracts, you're going to cause negative pressure. You're going to get a negative pressure in the pleural space first. Once you build up enough of a negative pressure in the pleural space, you're going to have a negative pressure in the lungs. The lungs will expand, okay? So we're going to increase volume. Therefore, we have to decrease pressure. So just like we were saying, if we contract the diaphragm, we're going to increase volume, right? Eventually in the lungs equals decreased pressure. Now, that makes sense from Boyle's law. What does that mean if we have decreased pressure? That means it's easier. You're causing a vacuum. Decreased pressure means a vacuum, easier for air to come in. All right, that's the principle there. And this is just more of the same. So on inspiration, you're going to get diaphragmatic contraction. You'll get a pressure, decreased pressure in the pleura here, and then eventually decreased pressure in the lung. Therefore, it's easy for air to come in. The opposite is true. When you relax the diaphragm, you get decreased volume, therefore increased pressure here. So air is going to go out. So it doesn't take a lot of work to exhale, right? It's more of like this reflexive response. And that's the idea. The less work you have to do with respiration, the better. This is kind of what I was talking about before, if you want to read that. All right, so let's go to breathing cycle. This reminds me, I hope they fixed one of these slides because I don't think they fixed it in a couple of terms now, but I'll get to it in a second because it's very confusing, but y'all could let me know if they fixed it. Anyway, so we're talking about some definitions here. The transmural pressure, the pressure mural means a wall. So the pressure across the wall. And then the transpulmonary pressure. So we'll see a little bit of this coming up. But again, we're looking at this pressure difference here. If you contract the diaphragm, see it takes here a -5 of pressure before you even start contracting. And it varies from person to person, but they're trying to make a point that you need a different pressure variable here before you get a negative pressure in the lungs. So you could actually calculate it. I just put this in there for completeness. They're not going to make you calculate anything like this, but this is just how they calculate this transpulmonary pressure, right? The pressure in the airway minus the interpleural pressure. That's going to be your pressure against this gradient. All right, now this works with Boyle's law again too, because look, as we increase pressure on inspiration, as we increase volume on inspiration, we're decreasing pressure. And when you breathe out, you're decreasing volume, you're increasing pressure, therefore you're able to breathe out. So as you can see here, they're completely, for the most part, inversely proportional, okay? And you can see the flow here. So you could follow this along, breathing in versus breathing out and how it correlates. But I just wanted to illustrate again how Boyle's law correlates with the lungs. All right, and then this is kind of the whole process where we go through the whole process of inspiration, okay? I don't want to get too bogged down with this, but the whole idea is that the compliance is inversely proportional to elasticity, okay? And it's tricky because elasticity has to do with the recoil, right? Compliance is just how much you can fit. So if the rubber band is too tight, too elastic, it's not going to expand well. So just keep in mind this concept of compliance is inversely proportional to elasticity. You kind of want a middle ground. You want to be able to have compliance. You want the rubber band to stretch a little bit to get enough air in, but you also want it to be able to contract enough to get air out. Now, if you're wondering why these lines are different versus inspiration versus expiration with pressure, this transmural pressure, it's just because when you exhale, you kind of have to open up airways a little bit with the musculature. So you do see this, I think there's, yeah, that's this word, hysteresis. So it has to overcome this airway resistance, frictional forces, and the elasticity. So this is why it's not a direct correlation between inspiration and expiration. Again, this, I don't even know if that they'll test you on this. This is very much more low yield. So, but if you came across this word, that's what they're referring to. All right, now, this is where we talk about surfactant. Now, in principle, actually, well, yeah, I don't think my slide's coming up in a second. Okay, so in principle, this idea of surface tension is all acting towards the middle. So if we're assuming we have no surfactant here, the surface tension is going to cause a collapse of this circle, right? The surface tension is going to push and collapse the circle because that's what the tension is on the outside. It's an inward force. Now, what you need to keep in mind is with the increased radius, you're going to get decreased pressure. It's a good concept to understand. Increased radius means decreased pressure. Now, this is why that's important. If we have an increased radius, we have decreased pressure, right? So this one has increased radius, so it has a decreased pressure compared to this one. Now, what happens if we have air in these? Well, if this has increased pressure, it's going to cause all the air to go to this circle or this alveoli, right? And so therefore, this is going to collapse. And that's the idea is that increased radius equals decreased pressure. Now, you can see how this creates a problem, right? Because if you have a bunch of alveoli in the lungs and some are smaller than the others, all the small ones are going to collapse and all the air is going to go to the larger ones. Now, this is the concept of surface tension. So the body has to evolve a way to being able to cope with this. Now, if you were looking at this like me the first time you saw this, if I was to turn this valve, my thought would be that all the air, because there's more air over here, would go to this little small balloon. That makes sense, right? Well, that's not what happens, actually. I don't know if it's considered a paradox or whatever, but if you open this valve right here, the air from here, this purple balloon, is going to go to this orange balloon. And I think this very much illustrates, and it was like a light bulb that went off in my head to kind of explain how this idea of surface tension works. So turn the valve, this balloon or alveoli would collapse due to surface tension, okay? And that's the same idea. This has increased radius, so therefore it's decreased pressure. If you don't believe me, you could type that in and go watch it. But yeah, so that's the idea. So the body has to develop surfactant. Now, the surfactant is going to directly oppose the surface tension, okay? So that surface tension is going to cause that's a great circle, an inward force to collapse it. What the surfactant is going to do is going to cause an outward force, okay? So it's going to counteract that surface tension, therefore allowing the smaller alveoli to stay open. This is why if you have a premature child that's born before 20 weeks, they end up with respiratory distress syndrome because that surface tension is too much to overcome. You don't have the surfactant to push outward to keep the alveoli open, okay? Right. Not that I find this important at all, but we did have a question asking about this. So you're just gonna have to memorize it. I think A and D go together and B and C go together. So I don't know, that's super important, but it was tested. So there you go. All right, now, this is what makes the surfactant idea so interesting. So follow along with me here. Right, so this is area. So the alveoli is largest at this point and smallest at this point, okay? Now, so when do we need the surfactant to be most condensed? So the more condensed it is, the more active it is, right? The more able it is to surround the alveoli. Well, we need it to be most condensed and most, condensed or encompassing the alveoli when it's the smallest. Because remember, and that's 0.3. The alveoli is the smallest at 0.3. So at 0.3, there's all of the surfactant is, you could see, kind of bunched up right here, right? So it's actively pushing outward on this little alveoli, okay? And why is that important? Well, that goes back to the idea that smaller radius, right? 0.3 is the smallest radius right here, has an increased pressure. So conveniently, we have a lot of bunched up surfactant molecules to have a lot of force outward. Okay, this is an important concept you need to wrap your head around. Now, once we get to the larger, the larger point, right? 1 is the largest. Now, at this point, the surfactant's it's not super bunched up, right? So, but again, once we get to the larger alveoli, we have increased radius equals decreased pressure, right? So it's not super important that this alveoli is bunched up. Now, it does play a part in you over expanding your alveoli. So it will prevent hyperinflation at this point. But the key thing to remember here is when the alveoli is at its smallest, it has the most pressure. So at the point where there's most inward pressure, you need to have the most outward pressure too. And that's why the surfactant looks like this. We did have a question like this asking us kind of where everything fits, but that should make sense. They're bunched up here because they need to fight off that pressure, okay? Hope that made sense. Okay, try this one. And somebody's welcome to chime in and speak up and explain it to me just to make sure we got all this straight if y'all want. If not, I'll go through it again. Yeah, the surfactant's a little blue. Yeah, I'm sorry. I should have pointed that out. Yeah, the surfactants are these little molecules, the red and blue. That's all surfactant. Yeah, okay. So somebody speak up and tell me, what's the surfactant gonna look like from these two different points? Anybody? This point versus down here. When is it gonna be most active?
Most effective at the lower end where it says crosses 0 and 20?
Yeah, exactly. And so the alveoli is the smallest at that point, right? So yeah, at that point, it's the smallest, so it's gonna have the most pressure, the smaller radius, the increased pressure. So that's when you need the surfactant to work. So those blue squigglies will be bunched up. At this point, it's not as important, okay? So they'll be spread out. Cool, thank you. Right, full inspiration versus full expiration. All right, try this one. Sorry, so you can see the lungs fully inflated here and fully deflated here. Oops. All right, sorry. Not good, right? So you're thinking some sort of, excuse me, obstructive disease. This is called barrel chest, this increased anterior posterior diameter. The reason this happens is because of air trapping. They're able to get air in, they can't get air out. So you get this increase in lung volume. So eventually, to compensate, the chest wall gets larger, you get this barrel chest. These are the pink puffers. Yeah, because they can get air in, they can oxygenate, they can't get air out. So, whoops. Okay, cool. Yeah, so this is emphysema classically. Now, if they were talking about mucus buildup or something like that, or a lot of coughing up mucus, you'd think chronic bronchitis. For super bonus points, somebody tell me why they said no. This is why did they say this? Somebody impress me. Anyone?
Is that
Yeah.
one concept?
Yeah, because of A, right? What you need to know is that, and this is a key thing that you can keep up with, is that with alpha-1 antitrypsin deficiency, you also have liver issues, okay? So if it'll look in the lungs, it'll look very much like emphysema, but in the question, in order to differentiate them, they're gonna talk about liver problems, okay? Good job, yeah. Okay, now the point, well, the idea here is that with emphysema, you're actually moving this equal pressure point down the bronchi, okay? So as you move this equal pressure point down here, it causes the bronchus, the bronchi, the conducting zone to collapse, okay? And that's why you get this obstructive lung disease. Okay, because you get air in, but once air is here, you've moved this equal point pressure down, so the lung will collapse. Now, the interesting thing about this is what you'll see is with people with emphysema, they breathe from pursed lips, is what they say. So they breathe against pressure. Now, the point of them breathing against pressure is it will actually bring this equal pressure point back towards normal. OLD means obstructive lung disease. Sorry. Yeah, so yeah, you move the equal pressure point down towards the alveoli, and that will cause collapse. So the idea of them breathing against pressure or breathing against pursed lips, anytime you see that, you're thinking of obstructive lung disease like COPD, like emphysema, right? So, and the point of them breathing against pressure is you're trying to open up this airway. Physiologically, it'll open up the airway and it'll allow them to actually breathe out properly. And by opening up the airway, you're moving this equal pressure point back towards equilibrium. So if you're curious why they do that, that's the idea. And it's more about here. So you can see here, this is with emphysema, you're moving this equal pressure point all the way down to the alveoli. So once you get air in and you try to breathe it out, everything collapses. So they breathe from pursed lips, and it helps to bring that pressure gradient back towards equilibrium. Okay. Yeah, that's what I was saying. Yep, same thing. All right. Cool. So if we have the red line here is normal, we're looking at pressure and lung capacity. So it looks like patient 1 has a high compliance. So what that means is patient 1 is trapping air, okay? So this is obstructive lung disease, right? Because look at the lung capacity, right? You're holding on to a lot more air. This is normal. So this line must be restrictive. You're not, your lung capacity is greatly decreased. And that's because you can't get air in. We'll talk about this a little bit more later, but this is what this graph is illustrating here. So yeah, pink puffer cannot get air out. That refers to line 1. High compliance, they can't get air in. So lung compliant, low compliance would be like with fibrosis. That means you can't properly get air in. So you can't fill up your lungs properly. Okay. This is just to illustrate that if you didn't have the outward force of the chest cavity, the lungs would collapse. Okay, so there is an equal and opposite force between the chest wall that wants to go pop outward and the lungs that want to go inward. So it's important to keep this equilibrium standardized, because the outward force of the chest cavity in red equals the inward force of the lungs. So everything stays standard because they oppose each other. And this is your functional reserve capacity, correlates to this line here. So any deviation of this, think about it if you had some sort of tension pneumothorax, right? You put a tube, or I'm sorry, you had some sort of injury here. You would affect this, right? Because your chest wall is going to pop out due to the injury, and the lung's going to end up collapsing, right? So the fact that they can oppose each other allows the lungs to stay open. All right, and again, you could see when patients have asthma attacks, you could see that the lungs collapse. So it is considered an obstructive lungs disease because it is easier to get air in than air out. So once the air collapses, you could see that the lung volume will actually go down due to the high resistance. Okay. Dynamic compliance falls. So their ability to change the ability to expand, dynamically changing the ability to expand falls because the asthma attack will cause constriction of the bronchioles, right? So again, you're not going to be able to get air in or air out for all intents and purposes during those asthma attacks. And that's why the lung volume goes down. All right, try this one. All right, and this is just the idea that when you have an exercise stress test, you do develop lactic acidosis. So you're going to get a decreased arterial pH. So when you talk about those graphs, when you talk about those graphs where, which we'll talk about in a little bit, where you get that right shift and left shift with oxygen exchange, the increased acid production will cause an offloading of oxygen in the tissues. Okay, so that's what happens, and that's one of the physiological responses to exercise. And that's what we're looking at here. So you need to know these, what correlates with what. Any sort of right shift correlates to the tissues, correlates to offloading of oxygen. Any sort of left shift is correlated with the lungs and oxygen binding to the red blood cells, to hemoglobin. Okay. Also, a left shift is correlated with fetal hemoglobin as well, because it's important for the fetus to be able to grab the oxygen from mom. Okay. So anything like increased acid. So like the question had lactic acidosis, increased carbon dioxide, which you would expect to see in the tissues. Exercise correlates with acid. High altitude and temperature, all of that's going to cause offloading. Also, this 2,3-BPG, which we'll talk about in a second, you see high quantities of this in the tissues, which means that the oxygen is going to be offloaded, okay? Low in the lungs, that means it's going to be bound. So it just kind of allows the oxygen to properly be exchanged between the red blood cell and the tissues, okay? And then this ventilation perfusion mismatch, it correlates. Now, you know, when you think about gravity, the lower aspect of the lung is going to be perfused better than the upper aspect. Well, oxygen's, or, you know, air is going to rise. So technically, the air is going to be up here. So what do? You have to find some sort of middle ground. So right around here is where due to the architecture of the lungs, the oxygen is able to properly find the vasculature. So this zone 2, the lower aspect of zone 2, is typically about the area where you have the most oxygen exchange. Okay, this is super important. You need to know how to calculate all of these. The thing I try to remember is any sort of capacities is when you add the volumes together. Okay, so the volumes are going to be independent of each other. Tidal volume is your normal breathing. Inspiratory reserve volume is if after you normal breathe in, anything additional to that, if you take a deep breath, will be added to that. Expiratory reserve volume is after you take a normal breath out, whatever you can additionally breathe out after that. And then residual volume is going to be the stuff that's in your lungs. You can't really do anything about it. Now, you do need to be able to calculate all the capacities. Remember, capacities add volumes together. So just be able to do this. Takes a little practice, but it kind of makes sense once you look at it. All right, spirometry. It's a way of analyzing your ability to properly inhale and exhale, mostly exhale. Post-surgery, usually patients need to do this, abdominal surgery and whatnot. It's important to make sure you're breathing out properly, your lungs are functioning properly, because you don't want any sort of consolidation or decreased lung compliance. Any consolidation or any buildup that's going to cause problems post-op. So forced expiratory volume in 1 second kind of is a good correlate of how well your lungs are working. Now, when we look at the obstructive versus restrictive lung diseases, we'll look at the differences there. So in obstructive, and this is a super important point, remember for obstructive, you can't get air out, okay? Obstructive means you can't get air out. So what we look at here is our numerator is going to be drastically decreased, okay? Versus our denominator is also going to be decreased, but it is not as much as the numerator, okay? So this is going to give us a very low number. And the point being is that you can't, in that first second, you really can't breathe out. Like, that's the whole idea. That's why you have the air trapping, that in pressure point, the whole idea of pursing your lips. The idea is that you really can't breathe it out, especially in that initial first second, which is the most important. And I'm sorry, guys, I really can't keep up with the chat while I'm doing this, but we'll answer any questions you guys had after. If we need to go back to slides, that's no big deal. All right, now restrictive lung disease, remember you can't get air in. So technically, these numbers should kind of correlate together, right? If you can't get air in, there's no air to breathe out anyway. So this is gonna be decreased, but they're gonna decrease proportionally. So if you decrease both, the overall would be decreased, but it will be proportional, okay? So because the numbers decrease proportionally, it may seem normal, okay? Just the ratios, okay? Like as in if it was, I don't know, 10/10, right, equals 1, right? This will change to 2/2, which is less, right? But your value is still going to be the same. So the value, if you actually looked at the individual numbers, they would have changed, but your overall value looks the same, right? But they like to throw that in on the questions. Like you have a massively decreased FEV1 versus total volume, and you'd be like, well, that's obstructive. All right, so it's a good giveaway. All right, try this one. What is cadet? I don't know what that is. I've never heard of that. Yes, okay, good, right. So chronic bronchitis is obstructive, right? Oh, right shift cadet. I don't know what that is. Maybe that correlates to CO2, acid, temperature. something like that. Oh yeah, I just used the one that's in first aid, so I'm not familiar with that one. Yeah, so basically you say chronic bronchitis, automatically you know that is obstructive. Therefore, you would expect your numerator to decrease much more than your denominator. So it's 50% of normal. Okay, good giveaway for these tests. All right, again, same thing. If it's obstructive, your numerator FEV1 will be drastically reduced compared to your overall. Restrictive, pretty much the same. All right. Yeah, and this is just kind of to point out these, what goes with what. Again, you'll get into some of these with pathology, but anytime you have fibrosis, you're not going to get expansion, so you're not going to get compliance. But, and then of course, obstructive means any of these problems, a lot of times has to do with smoking. Remember, chronic bronchitis and emphysema both fall under COPD, and then asthma, of course, is obstructive as well. Okay. There was a slide, I'm not sure if they ever corrected it, but if you've looked at this, the slide in the notes have these values backwards, okay? The larger number should be towards this axis. So I don't know, let me just see if I don't even think I didn't even bother putting in the one from the lecture notes, but I remember where the 8 was, it was like 0, 2, 4, 6, 8. It has to be backwards, and I'll explain why. Okay, so remember, inspiration is on the bottom half of the graph, expiration's above. So we're gonna make a clockwise loop real quick. So this is your reserve volume. This is normal. You're starting at about 1.8 liters, right? That's your observed volume. Take a deep breath in, right? Inspiration is below, and you're gonna go to 6, right? Your lungs are expanding. Now, are you going to go above the graph up here, and then you're going to breathe out? Okay, so just keep in mind, we're always going to go in this clockwise motion here, right? And then you're going to breathe out. So the point is, as you take a deep breath in, and you could follow it along, the volume graph, right? You're breathing in, you're up to 6 liters. You take 6 liters, you breathe out, you go back to where your residual volume is, okay? Now, the reason that's important is because we're gonna look at different diseases and the patterning. Remember, obstructive lung disease means you're air trapping. If you're trapping air, you have that barrel chest, right? You can't get air out. Look at where we're starting. Look at our residual volume. Opposed to being a normal 1.8, we're starting just under 4. That's a ton of residual volume that you're just no good, right? Everything's not collapsed, but expanded in your lungs to the point where it's just sitting in there and it's not doing any good. But the point is, you can't get air out, so you're trapping it. So we're going to do the same thing, but instead of starting at our baseline, we're starting just under 4. So we take a deep breath in, and look how much more volume you have to have in your lungs to compensate. That's why they get a barrel chest, right? You usually can be standardized at 6. You're holding over 8 liters of air just because you're trapping it and it's doing no good in there. Then you take a deep breath out, and you could see how this forced expiratory volume, you see this kind of shift in the curve here, is bad. So we go back here. The point, you don't need to get too bogged down with this. The point is, what you would expect is if in an obstructive lung disease, you're shifted to the left because you're air trapping. What happens with restrictive lung disease? Well, you're not getting air in, so your residual volume is much lower. Now you take a deep breath in, where our normal would be holding about 6 liters, we're under 4 at our total inspiratory, at our inspiratory volume, right? Total inspiratory volume capacity. And so then you breathe out and you go back there. So the point is that versus normal, obstructive is going to shift to the left, restrictive is going to shift to the right. Okay. And you could check out these variables here, but that kind of correlates with everything together. Remember, FEV1 is, our numerator is very much decreased compared to the denominator. Okay, so can't get air out, can't get air in. Great. All right, try this one. Oh, there you go, cadet. Okay, C is CO2, high altitude, BPG, yeah, 2-3 BPG, exercise and temperature. So you could use cadet for a right shift. That's level mnemonic. Thank you. Yes. All right, good. So if you, yeah, so right shift would correlate to restrictive, right? R for restrictive. Yes. Pulmonary fibrosis. Now, again, this is a good example how you could use the test to your advantage. Let's say you didn't know what a right shift was versus a left. You could still categorize these together. You know that these fall together. This one does not fall in the same category. Excuse me, hold on. So the one that's an outlier is going to be your answer. But again, right shift means you can't get air in. So fibrosis, decreased compliance. All right, I'll put this in here again because it's that. So asthma is, overall, it's an obstructive problem, but sometimes when you get asthma attacks, it's also hard to get air in. So it's not exactly cut and dry. Yeah. So sometimes when you have a direct asthma attack, the musculature is mixed up. Scoliosis, you mean sarcoidosis? Sarcoidosis, y'all will get into later, but it does end up causing fibrosis. That's all you really need to know about that. Okay, but y'all will cover it in much more detail when y'all get to pathology. All right, again, this should make sense. Make sure if the notes aren't changed that you need to fix this, that these numbers are correct. All right, let's see where we're at. All right, we should keep going. We'll do this. We'll take a break in a little bit. All right, so hemoglobin, it is made up, when you think about that quaternary structure, that means you're taking different proteins and binding them together. So you get out 2 alphas and 2 betas, and that they all combine together to make a tetramer. Inside of each of these is an iron, primarily in the ferrous form, which is Fe2. That's what you're going to want to bind hemoglobin. Fe3 is no good. So you want to keep it in the Fe2 form. Okay, so that's the idea of hemoglobin. Pretty interesting. Again, one of the problems that you'll see is if you have iron in this ferric form, it's very difficult to bind. So there is a problem called methemoglobinemia that y'all may have come across. They show, I think, yeah, I'm not sure if this is Photoshopped. I imagine it is, because look how blue they are. But the idea is that in this ferric form, you can't, in this Fe3 ferric form, you can't bind oxygen. So if you can't bind oxygen, you can't get it to the tissue. So you're going to turn out blue. What is important for you to remember, makes sense because it has blue in the word. Methylene blue is reductant. So it can change Fe3 back to Fe2. Okay, so you give these patients methylene blue and it takes their blueness away. It goes from 3 back to 2, so you can properly bind oxygen. And hemoglobin is very different from myoglobin. Whereas hemoglobin is transport in the blood, myoglobin is more of storage in the tissue. Myoglobin doesn't have that sigmoidal curve, okay? We'll get to that in a second, but the idea that hemoglobin can combine multiple or a total of 4 oxygens means it ends up having this sigmoidal curve, right? It's cooperative binding. And we'll talk about that in a second. But myoglobin just has a normal distribution curve with a Vmax. So it has to do with oxygen storage, but you can see the differences here, okay? This is the concept of cooperative binding. What that means is with each subsequent oxygen you bind, it becomes easier to bind another oxygen. So whereas myoglobin has a curve like this, because of sigmoidal binding, hemoglobin will have a curve like this. And this is the idea of cooperative binding. Okay, so if you look at the binding pattern on the curve, if you see something like this, you're thinking of cooperative or allosteric binding, we also call it. All right. And right, so you can kind of appreciate this sigmoidal curve here, but this is the idea of 2,3 BPG. So the main point you need to remember is that if you keep in mind that it's primarily in tissues, then it makes sense because 2,3 BPG will promote oxygen release to the tissues. The presence of 2,3 BPG means that the hemoglobin will have decreased affinity, meaning it'll want to get rid of it. Okay, so by definition, it's a negative allosteric effector. It does not promote binding in the hemoglobin, it promotes release of the oxygen from the hemoglobin. Okay, so if you have 2,3 BPG in the tissues, then you get release. That's the way I remember it. Keep it there so you get oxygen to the tissues. Okay, yes. All right, now y'all, we'll talk about this more next term when y'all get to DM, but in principle, you could see this here. So if you have a hexokinase deficiency, it's the pathway through glycolysis, then you're not gonna get to the point where you make 2,3 BPG. So you have less 2,3 BPG. What does that mean? That means you're gonna not be able to offload oxygen as well, right? You're gonna keep it on the red blood cell primarily because you don't have 2,3 BPG. Now, let's say you have a pyruvate kinase deficiency, which is over here, which means you will get a backlog of these reactants behind it, okay, because you can't go properly through the pathway. So there you will have increased 2,3 BPG, okay, because you're downstream of it. And so therefore you're gonna get increased offloading. Okay, so it's just, they just like to correlate it because it's a way of taking the glycolytic pathway and correlating it now with 2,3 BPG. But as far as if you just know this, you'll be fine, right? So if you have hexokinase, you're not going to be able to make 2,3 BPG or sorry, hexokinase deficiency. Therefore, you will get a left shift. You'll hold on to it. If you have pyruvate kinase deficiency, you know, increase backlog of the reactants. So you get increase 2,3 BPG, so you get a right shift, okay? Gonna offload it. Decrease O2 affinity for the hemoglobin. All right, and then again, this is like that slide we looked at that had to do with the right shift versus left shift. The Bohr effect has to do with this carbon dioxide. So again, if you have a lot of carbon dioxide buildup in the tissues, is going to promote a right shift, which means promote offloading. Because remember, when you offload oxygen, you're going to bind carbon dioxide as well. It has to exchange. So anytime you have increased carbon dioxide, your goal is to get rid of it out of tissue and get it back to the lungs so you can breathe it out. Again, this is here. I guess this is where I don't think first aid has that cadet mnemonic, but right, you need to know what goes with what. Like we talked about, I guess they use this ACE-BATS thing, but whatever works. And this is Dr. Mpadia's slide, and you can kind of see. So if we are in the lungs, you would expect decreased 2,3 BPG, so you get increased binding. Now, primarily carbon dioxide will be transferred in circulation as bicarbonate, okay, right here. So once you get the carbon dioxide out of the tissues, you make bicarb, you bring it back to the lungs. And then once you get to the lungs, you can offload the carbon dioxide, bind the oxygen, okay? Cooperative binding. Then the exact opposite in the tissues, right? Tissues, you have increased 2,3 BPG, you can offload the oxygen and you can, into the tissues and take the carbon dioxide out so you can get it back to the lungs. This is the same thing basically, but from first aid. All right, and so you can see, look, so this black line is the hemoglobin curve, and you can see it has this sigmoidal curve, but carbon monoxide has this, this curve here. So you could see that it binds much more strongly to carbon monoxide, binds much more strongly to the hemoglobin. And with just one carbon dioxide binding, it'll block all the sites. So this is why these are true, if you were curious. So it's much worse to have carbon dioxide bound than 50% oxygen on the hemoglobin, just because the carbon dioxide binds so tightly to the hemoglobin receptors. All right, now the importance of fetal hemoglobin is that it promotes a left shift. So it binds oxygen. It has a higher affinity for oxygen than the maternal red blood cell, which makes sense because you want the fetus to kind of pull the oxygen off from the mother so that the fetus gets proper oxygenation. Now, after about a year or so, 6 months to a year, you eventually start getting rid of this fetal hemoglobin and you get adult hemoglobin. And then glycated hemoglobin, y'all will worry about in DM. That's just a measurement for diabetes, because the increased glucose you have in circulation, you'll end up glycating the hemoglobin. And that's how they measure, that's how they diagnose diabetes these days. But you don't really need to worry about that right now. The point is that you see this pink curve right here. Hemoglobin F promotes a left shift, which means it has higher affinity. They actually use this for treatment of some diseases such as sickle cell, because some of the hemoglobin, the normal adult hemoglobin is messed up. So if they could promote the gene, upregulate the genes for fetal hemoglobin, these patients tend to do better with oxygenation. And this is why that fetal hemoglobin has that left shift or the higher affinity, because it actually will bind that 2,3-BPG less tightly. Remember, 2,3-BPG is a negative allosteric regulator, so it's going to promote offloading. So if fetal hemoglobin binds to 2,3-BPG less tightly, you have increased affinity, okay? So you might just have to think about that a little bit, but that's the whole idea behind that. Yeah, this is what I was saying. Your red blood cells live about 90 to 120 days. So your glycated hemoglobin, glycation is just non-enzymatic glycosylation, which means that all the extra glucose in circulation, if you have diabetes, so if your glucose is like 400 and you have all this extra floating around, it will non-enzymatically glycosylate the hemoglobin, which is measurable for the lifespan of the red blood cell. So they use this. Patients that go to their doctor tend to eat well for like a day or two. Diabetic patients, and they're like, yeah, my glucose is fine. But when you check them out over a 3 or 4 month period, you'll see that it has not been fine. So that's the idea there. Right, so 3 months, so say about 90 days. Now, when we talk about the hemoglobinopathies versus thalassemias, remember that hemoglobin problems such as sickle cell are qualitative problems. It's actually the structure is messed up. Thalassemia is a quantitative problem, means you don't make enough of it. All right, so hemoglobin is, they like to test specifically about this. It's position 6 on the beta change. It changes glutamic acid by valine. The problem is glutamic acid has a negative charge. Yeah. Yes, sorry, yes, it's definitely. So it's a negative charge, and you're changing a negative charge to a neutral charge. So what this actually does is it create in the red blood cell, it creates this hydrophobic pocket, right? Because it's neutral, and this is what causes that sickling effect. Now, when you get a bunch of sickle cells that come together, they tend to bunch up in circulation like this. So they'll bunch up in the vessel, and that causes pain to these patients, pain crises, okay? So that's the idea there, but they very much like literally this exact sentence or statement right here. And that's why they aggregate. So when these patients are in states of low oxygenation, there's some athletes actually that have this, like can't play up at the Denver stadium because it's Mile High Stadium. There's decreased oxygen levels that could lead to a sickle cell crisis, but it's pretty interesting. Down in New Orleans, where I used to work, it's a huge sickle cell population. So a lot of these kids are really sick, and unfortunately they need strong medications, pain medications to compensate for them. So yeah, you get a missense mutation, missense meaning you're changing one amino acid. So you're going from a negative to a neutral. All right. Yeah, and this is more of the same here, glutamate or glutamic acid for a valine, and it changes the surface of it. And again, you could see that here. You're changing a negative charge to a neutral charge, causing that hydrophobic pocket. Again, you can see this is painful, right? It's going to cause ischemia to the area downstream of it because you don't get proper blood flow. Now, as I mentioned earlier, you've come across this drug before, hydroxyurea. What they actually use it for in these patients is to upregulate fetal hemoglobin. So you're going to end up, if y'all remember back in the day, y'all talked about hemoglobin deacetylation. Deacetylation will promote gene transcription. So you're going to have gene transcription of fetal hemoglobin. There's nothing wrong with their fetal hemoglobin. It's just they're adults, so they don't really use it. But if you form this euchromatin of fetal hemoglobin, you can kind of compensate for the fact that their adult hemoglobin is all messed up. And you can see that a lot of patients in the African descent have that primarily, but the reason is because there is this selective advantage for it. The point is that the malaria life cycle lasts about 90 days, right? So the lifespan of the red blood cell. These patients that are heterozygous for sickle cell, their red blood cells don't last that long. Therefore, the malaria can't properly replicate in their blood. Okay, so these patients don't have sickle cell so bad, right? Because they're heterozygous and they don't necessarily die from malaria. So they have this selective advantage and they tend to live in areas of where malaria is present better. So that's why that's that. And there's also this hemoglobin C. It's a much less common variant. You're actually changing a negative, this glutamic acid, to a positive. So just keep in mind, it's lysine. But typically these patients have mild hemolysis. So they'll have red blood cell breakdown, their urine will turn red, stuff like that. And the point is that it tends to crystallize in these red blood cells. But if anything, they'd probably test y'all on sickle cell. The important thing to remember here is, remember if we looked at this, if we have, remember when we do this electrophoresis, we go from a negative to a positive, from a cathode to an anode. So anything that is negatively charged is going to go towards the positive end. All right, so we said glutamic acid is negative, so it's going to go to the positive end. So you would expect the normal line to be all the way over here. If we change the negative to a neutral, it's not going to go as far, but it will go farther than hemoglobin C, which is a negative to a positive. Positive is going to stay near the negative anode, okay? So, and you can see that here. So I think it's important that y'all are able to differentiate if they give you lines on this graph, what correlates with what. The normal one will go the furthest, then someone with sickle cell would go next, and then someone with hemoglobin C disease won't go that far. So just keep in mind, they could point to these or label them, but it's important to be able to know that because they're testing to see if you know the genetic makeup of these amino acids. Now, as we said, thalassemia is more of a quantitative problem. So you're making proper hemoglobin, you're just making less of it, okay? Whereas in sickle cell, you were making enough of it, but they were all messed up. So this is a qualitative problem. So there's alpha thalassemia, beta is more common, but you can see alpha thalassemia, you kind of just need to know some of these definitions that go with it. So primarily you get this unequal crossing over when they recombinate. But what I want, and you can see that here, this crossing over effect, but this is what's going to be important. Classically, if you have one or two gene messed up, you won't really get clinical symptoms, maybe mild anemia. It gets really problematic when you get three. This is referred to as HBH, okay? We have a 3-gene problem. And if you lose them, if you have no alpha chains, obviously you can't make any hemoglobin there. So you're going to get hydrops fetalis. It's not compatible with life. The fetus has a lot of edema and buildup, which is hydrops, fluid buildup, but it's not compatible with life. So typically when they talk about this, they're going to talk about hemoglobin H. Sorry, another name for this is Bart's. Wait, which one's Bart's? Is that 3 or 4? I think I have a slide coming up. Do y'all know? 4. Okay, Bart's is 4. Okay, yeah. So hydrops fetalis is 4. Thank you. But the one that the primary test you on is hemoglobin H. So again, you're making you're actually making the right change. You're just making less of them, right? Quantitative, less quantity of them. All right, good. And then they go into this idea of cis versus trans. I think I have, yeah, I'll show you on the next slide. But this is, yeah, here we go. Hydrops fetalis or hemoglobin Bart's, 0 alpha change. That's a huge problem, right? If you don't have any alpha change. Hemoglobin H means you lose 3. And what happens if you only have 1 of the 4, right? You've lost 3. These betas end up making tetramers, and that's no good either. You can't have 4 betas. It just messes things up. Okay, so what you could see here is classically a cis, meaning it's on both, versus a trans. It tends to be worse because if you get this cis regulation, you're going to get both. Whereas trans, you're only going to get 1 either way. So just basically all you need to know is cis tends to be worse than trans, just statistically. Okay. Now, beta thalassemia is more common. There's different variations of this. Same thing is with alpha. And what they exhibit that you should know is allelic heterogeneity, meaning on the same gene, you can have different mutations, right? Different alleles on the same gene causing thalassemia. So a beta plus is decreased gene expression, where a beta 0 is complete suppression. So depending on how bad it is, obviously would depend how bad the symptoms are. So major, you're going to have very low levels due to this beta globin gene of the adult HbA, which is adult hemoglobin. So you get very little, and then intermediate just has some beta pluses, some beta zeros, and minor, you're usually not going to be symptomatic for it. So remember, you can have the beta 0 or beta plus, but the more you have of them, the more mutations you have of them, the less available adult hemoglobin you're going to have. Now, what would you expect with that, the body to do? Well, we do have backup versions that aren't common in people with normal hemoglobin, but this HbA2 will be elevated, and this comes up again. You will actually get elevated levels of fetal hemoglobin, and this is to compensate for the fact that you're not getting a lot of quantitative development of adult hemoglobin or hemoglobin A, okay? Again, don't forget that. Now, what actually happens when you have this? You're not making a lot of quantity again, right? So in these, you're not having, so the body's always telling you, you need to make more. You're not making enough hemoglobin, right? So it's going to tell where you actually make red blood cells in these, in the bone, you know, in the bone marrow. It's going to constantly be in a state of telling it to keep making more, even because you don't have that quantitative amount of it. So they talk about this spiking or this crew cut appearance, what you'll see, and that is just indicative of extramedullary erythropoiesis, or trying to compensate for trying to make more red blood cells. Extramedullary, you're just trying to compensate for the fact that you don't have enough. So you could see this, and you get this larger jaw formation, and it's just this hypertrophy. You're always cycling through trying to make more, but you just don't have enough. All right, so again, as I said, at about 6 months is where you're going to stop making this fetal hemoglobin. And at that point, you try to give them iron, and you try to compensate with making fetal hemoglobin or hemoglobin A2. But that's the point. The whole thing is, if you can give them iron and try to control their diet with these complications, you can kind of, but it's not an exact science. They really don't have a way of curing it, but except by doing bone marrow transplants, but you have to do that regularly, which is also a pain on the patient. But the point I wanted to point out here is that about 6 months, you lose that fetal hemoglobin. That gamma globin is part of the fetal hemoglobin chain. So that's when the patients start to be symptomatic, okay? So up until about 6 points, they're fine. 6 months, they're fine, but then it gets bad. All right, hemophilia A, you get bleeding into your joints. If you ever see here or see pictures of bleeding into your joints, that is indicative of hemophilia. So it's X-linked recessive. A correlates to factor 8, 9 correlates to factor B. I'm sorry. 8 correlates to factor A, 9 correlates to hemophilia B. We'll take a break in a second. Yeah, so you get these bleeding into the joints. So remember when we talked about factor 8 and factor 9, y'all did do this, right? When did y'all do this? In cardio? Yeah, we did this in cardio, I believe. Somebody could correct me if I'm wrong. Yeah, y'all did this. Okay, great. All right, cool. So this is a little bit of review. Remember, so this is the intrinsic pathway. So 8 and 9 fall in that pathway. So if it's not working properly, you get this abnormal bleeding into joints. So a little bit of review. And then the genetics behind it. Factor 8 typically involves a large inversion. So 8's usually a bigger problem than the allelic heterogeneity, whereas 9 correlates with just smaller point mutations. Not that this is super important. Do y'all know what would be elevated if we checked the labs for hemophilia? Remember, the intrinsic pathway correlates to APTT. Okay, so that would be elevated. Your PT would be fine. Okay, perfect. We can take a break in a second. Okay, just this last thing. Remember this skewed X chromosome inactivation. So the idea is that typically, since it's like for hemophilia would be an example, you wouldn't really see problems because a lot of the affected, the mutated form is going to be, at least typically you would think half, right, would be turned into that bar body formation. So you have enough of the normal X chromosome to compensate. But sometimes you get this skewed X chromosome inactivation, which just means for whatever reason, the mutated form may be around 70%. Maybe it's just sheer luck. You just got bad luck of the draw and 70%. So you may, even though the patient is heterozygous for it, you may end up being symptomatic just because for whatever reason, the mutated form is more common. So that's what that means. So just a little bit more of the genetics behind it. And let's take a 5-minute break, please. I'm go get something to drink. All right, are we ready? Let's finish. Yeah, I think it's good. Yeah, we're good. All right, so partial pressure just breaks down to what each of the components make up pressure-wise. So some of these equations are important, some aren't. Oxygen is always going to be 21% of atmospheric pressure. For any of you that dive out there, it's super important. When you talk about nitrogen toxicity, the bends and stuff like that. But yeah, so I don't know that they're going to give you any sort of these hard questions, again, because you don't have a way to calculate anything. So your minute ventilation, right? So would be your tidal volume times frequency. Every time you breathe in, times how many times you breathe, right? Wait, hold on, let me make sure. Yeah, breathing frequency, yeah, sure. So 12 breaths a minute. So you can calculate it over a minute, okay? So that's how you do that. And that tells you how much volume brought in per minute, okay? Dead space is basically just going to be your conducting zone, all right? In people that are patients that don't have any respiratory problems, the anatomic dead space would just be the conducting zone. The problem is when you have these smokers and patients that have destruction of the alveoli, anytime that you're supposed to have oxygen exchange, and it's not happening because of maybe fibrosis at the very end of the alveoli, that becomes dead space, right? It's supposed to be areas of exchange of oxygen, but if that membrane's too thick or if it's fibrotic, then it just essentially becomes dead space. So just know that in patients that don't have any problems, your dead space is just going to be that conducting zone. The respiratory zone is where you're going to have proper exchange of oxygen, but if there's some sort of problem, that may increase the dead space. So we can see here, the dead space is, again, conducting, and the alveolar ventilation or the is where you're going to get the proper exchange. Okay, and you can calculate that by just subtracting the dead space. Once you do that, you can see exactly what the alveoli is ventilating. All right, and then again, it's not super important, these different methods. I think, yeah, Bohr's. Okay, so Fowler's, I don't think they're gonna test you on it, but Fowler's, I believe, uses some sort of nitrogen. Is that right? Do y'all remember? Anybody? Fowler's, is it nitrogen some sort of, or is it carbon dioxide? Anyway, I don't think it's super important, but maybe, oh, here we go, it's right here. So Fowler's, yeah, uses that nitrogen. So you have to do this in a lab or at the hospital. So you use nitrogen to compensate, and they can actually check the air you breathe out, the components of it, and they can see exactly how much anatomical dead space you have. See if there's any sort of pathology there. Now, the easier way to do it is by you make some assumptions, and then you take carbon dioxide, the carbon dioxide, and you can measure it versus what you breathe out versus what is actually in your blood, like an arterial blood gas. You could do that, and you could see, and then they could calculate it that way. Okay. So again, you have to make these assumptions here that the alveolar carbon dioxide correlates to the arterial carbon dioxide. Okay, so you would expect that the carbon dioxide that crosses over the alveoli would correlate to what's in the blood, which makes sense because that's exactly where it goes. Okay, so you can see here, if we're going from left to right, how everything exchanges. So we're coming in here, and you're going to have a lot less oxygen and a lot more carbon dioxide. So again, when you get to the alveoli, you can exchange, put oxygen in, get rid of carbon dioxide, and then as you go throughout. But this is just the idea of how you get that gas exchange. A few more equations. Yeah, I mean, I would be safe and try to learn these, but I don't know how many will be tested. It's kind of hard to guess these things. So it is worth knowing. Unfortunately, it is strict memorization at this point. Then the AA oxygen gradient correlates what is actually crossed, or what enters the alveoli versus what is in your artery, right? So it talks about what is the crossover. So are you getting proper exchange from the alveoli to the through the blood? So if there is some sort of problem in that, say some sort of emphysema where you get destruction of the alveoli, if the AA oxygen gradient is too high, then maybe there is some sort of pathology going on. The important thing here is that you never correlate hypoventilation with a change in AA gradient, because you would expect decreased oxygenation in the blood, but because you have hypoventilation, you're also getting decreased ventilation to the alveoli, okay? So both are gonna be decreased. We're not saying there's a problem in the ability to exchange from the air to the blood. We're saying that you're just not ventilating properly. So you're not getting enough in the alveoli, therefore you're not getting enough crossover to the blood. Okay, and then again, this kind of looks at, I mentioned briefly earlier, this VQ ratio. So if we look at the idea of ventilation versus perfusion, remember when you're at the upper aspect of the lung, ventilation, your breathing is going to be a lot higher than the perfusion just due to gravity. Then at the lung, it's opposite. Again, because of the perfusion, it's going to be higher. So there's this nice equilibrium point where everything comes together. It's about the zone 1. It's kind of in between zone 1 and zone 2, but where that ventilation perfusion kind of matches up. And so the architecture of the lung just allows for proper expansion there, so the air can get there, and then the blood flow kind of equals out there as well. So it's a perfect place where most of the ventilation perfusion works out together. So we kind of talked about this, perfusion at the top. Yeah. So let's see. So vasoconstriction. So obviously, if you have areas where you're not getting proper ventilation, right? So let's say, I think there's, yeah, here we go. There's a picture of it coming up. So we can look at it here. So let's say you had some sort of blockage in your airway. How would you compensate with that? Well, you would be able to vasoconstrict the artery there. Now, what does that do? Well, that says that if you're not getting proper perfusion here, if you're not getting proper ventilation here, then there's no point in perfusing blood through there, right? So it's a compensatory mechanism. You're compensating for the fact that there's not proper airflow, so there's no point in perfusing it. Now, this is how it would work out properly. If the area is going to be ventilated well, then you're going to be able to perfuse it well here. And then you look at the opposite here. If you have some sort of pulmonary emboli or something like this, obviously there's no blood flow, so there can't be any gas exchange there too, okay? But primarily you're going to regulate this by vasoconstricting or vasodilating. Vasodilate the areas that have high ventilation and vasoconstrict areas with low ventilation. That's why this, let me go back, that's why this works out, okay? If you can ventilate properly in this area, let's go ahead and perfuse it. We'll get as much oxygen exchange at that point as we can. Okay, so again, calculating AA gradient, if I bet money and they asked you one of these equations, this is a good one. Remember, we're trying to measure that thickness of the wall, right? We're getting air into the alveoli. Are we able to get it from the alveoli to the blood? That's what we're testing here. If you have a high gradient, that means you're getting a lot of ventilation, but the perfusion is not allowing it to cross over, okay? So here, let's say you would expect a very high AA gradient here. You're getting the proper ventilation, but no perfusion. High, so this big A is high, right? You're getting proper ventilation, but this perfusion, this little a is low. So big A minus little a, right? That's a problem, not good. All right. All right, so again, point want to make here again, hypoventilation. Remember, we're decreasing big A, therefore decreasing little a as well. So we're not really going to get a high AA gradient. But if for whatever reason we have that ventilation perfusion mismatch and it's not working out well, this AA gradient will be elevated. Some sort of shunt or a blockage can cause decreased ventilation or perfusions. Therefore, you have to compensate by vasoconstricting or decreasing the airflow to that area. So just keep in mind, anything that's going to affect one or the other is going to affect your ability to transfer from air to oxygen. Hold on. Excuse me. All right, let's see. And if you're one of, oh goodness. Oh, sorry about that. If you're one of those people that like tables, you can see here how you would compensate. Remember, if you have hypoxemia, it means you have decreased oxygen in the blood. Now, is the AA gradient normal? Well, yes, that means you're just hypoventilating. But if you have a large AA gradient, you must have a shunt or diffusion problem. What if you give extra oxygen? Well, it doesn't matter if you have a shunt, like shunt meaning blood. Even if you give extra oxygen, where's the oxygen going to go if there's no blood flow? Okay. Now, if you do correct with oxygen, that means you're able to compensate for the, well, if you give extra oxygen, you're helping the ventilation coefficient or the ventilation aspect of the equation. So if you could increase ventilation, then you know the problem was there by, okay, let me explain again. Okay. So if you give extra oxygen, if you're not getting blood flow, they won't change the effect. regardless of how much oxygen you have. If there is a ventilation problem and you give increased oxygen, it should help, right? If you're getting extra oxygen, it'll help with that oxygenation. And then you could try to correlate it with the carbon monoxide test that they do, which is a little more advanced. I don't think they'll test y'all on that. But if they use that, then you can correlate to see if it's a VQ mismatch, right? The ventilation perfusion mismatch versus a problem getting blood across the actual barrier, so that AA gradient. They just use carbon monoxide because it has an effect of freely going across the membrane, so they could actually measure that. So if it doesn't actually go across, then there is a diffusion problem from the alveoli to the blood. All right, then when you talk about high altitude, remember any sort of high altitude is going to cause a right shift, right? You're going to increase oxygen delivery to the tissue. So you can kind of see how it goes through the process. You're going to end up hyperventilating, but over time in a few days or weeks, you get increased 2,3 BPG. And that's the idea. If you do that, you're going to get, remember, it's a negative allosteric effector. So it's going to decrease the hemoglobin's affinity for oxygen, which will promote offloading, okay? Over time, you can get increased EPO or erythropoietin. Y'all have learned about that. That's just gonna cause increased red blood cell production, right? More red blood cells, more ability to carry oxygen. Some of the problems, if you ever went climbing, you know, climbers worry about pulmonary edema. Anytime you feel like you get any pulmonary edema, that can often lead to cerebral edema. So they actually give Viagra for different reasons, but it helps. Sildenafil will help with the pulmonary edema. Side effects, can't comment on that, but yeah, you could actually, you can correct the pulmonary edema with that. But if you do get pulmonary edema, you need to descend the mountain quickly because you're worried about cerebral edema, okay? All right, we're gonna briefly touch on glycolysis. Y'all will not be highly tested on this because you do an entire module on metabolism next term. So let's go ahead and try a question here. All right, so a lot of words to basically ask you about substrate level phosphorylation. Substrate level phosphorylation is going to be your ability to make ATP at the level of the substrate. Can you form ATP? So phosphoglycerate kinase is one of those steps. So we're gonna look at these in a second. These steps, so hexokinase and glucokinase are basically the same thing, except glucokinase is in the liver, hexokinase is in the tissues. So if the Vmax is higher for glucokinase, it could kind of grab more of the glucose, whereas Km has an increased affinity. You would want an increased affinity for glucose in the muscle. Beyond that, y'all will really talk about this later. We don't need to talk about it too much now. Now, when we talk about this, you're gonna have require ATP in the very beginning and then produce ATP, AKA substrate level phosphorylation, a little bit later on. So when you use ATP, it's just the process. If you use a little now, you can make more later. So the process of hexokinase and glucokinase, you're going to use ATP there, and also at the phosphofructokinase step 1, PFK1, and that's going to be basically your rate limiting step. Now, when you talk about substrate level phosphorylation, you need to know these two enzymes. These are going to be where you form ATP, okay? And this is an important slide. It kind of points everything out. Rate limiting enzymes are basically going to be these three at these points. And then the points where you're actually making ATP in glycolysis, Y'all have all learned this in undergrad, and then this is prior to the Krebs cycle. So this is the glycolytic pathway and substrate level phosphorylation. These two are going to make ATP. We talked about this. Remember, if you have a hexokinase deficiency, you're not making 2,3-BPG. Therefore, the hemoglobin will hold on to oxygen. At pyruvate kinase, you're going to get a backlog of these reactants. So you're going to have increased 2,3-BPG. Therefore, you'll get increased offloading or a right shift. So hexokinase left shift, pyruvate kinase right shift. Okay, see that here. Okay, and same principle here. This is that pathway where we actually make this 2,3-BPG. You use mutase as the enzyme. It's just kind of a side pathway that goes through it. But kind of talked about that already. Sorry, did I have a question? Phosphoglycerate kinase is not rate limiting because you're not using energy at that step. But y'all are going to get into that much more when y'all get to DM. Those rate limiting enzymes typically are the ones that require energy. So there's a pathway, and I mean, it's not super important now, but the rate limiting enzymes aren't bidirectional. So you can go from the process of taking glucose and making energy, or you can go use gluconeogenesis to basically make glucose. So there are certain enzymes in the pathway that don't go both ways. They're not bidirectional. Those are your rate limiting enzymes, the ones that only go one way, and that's standardized just so that you have specific steps where you can stop the process. Otherwise, again, this is more than you need to know, but the idea of glycolysis versus gluconeogenesis is very much an on-off switch. You're either going all one way or all the other way. So it's important to have unidirectional steps. That way you can say we're definitively going towards glycolysis, or we're definitively going towards making energy, okay? So those unidirectional steps are rate limiting, and those navigate that landscape of going one direction. All right, same thing here, more words about this process. Y'all might get a question about that for sure. All right, so problems. When you look at pyruvate kinase deficiency or even hexokinase deficiency, you're going to end up with hemolysis. Why do you get hemolysis? Well, eventually these sodium potassium ATPase are compromised just because you're not getting proper ATP. The process of pumping out sodium and pumping in potassium is going to require ATP. So if you have some sort of process in making ATP, then you're going to not be able to properly, shuttle the sodium potassium in the right directions. And when you can't do that, you get a lot of increased water in the cell, because remember, water is going to follow sodium. So if you can't pump the sodium out of the cell, you're going to have a lot of sodium in the cell. Therefore, you're going to get a lot of fluid in the cell. The cells are going to swell and they're going to lyse. And that's kind of the idea there. Now, we talked about glycolysis from undergrad. You remember the mitochondria goes with aerobic glycolysis. That's the ideal pathway. It makes much more ATP than anaerobic glycolysis. But things such as red blood cells, which don't have a mitochondria, have to undergo anaerobic glycolysis. Therefore, you end up with lactate production. And and that the Cori cycle is the process of getting the lactate back to the liver so you can reuse it. And that's kind of what they're talking about here, this Cori cycle, this lactate production, remember, goes through anaerobic glycolysis. The Cori cycle is what takes it from the red blood cell back to the liver so you can remake glucose. And obviously lactic acidosis will fall under metabolic acidosis. We will cover this at length when we do renal next week, but the different acidoses and alkaloses are going to be super important. There's like 20 questions on the exam when y'all get to that. We'll talk about that much more later, so don't stress on that right now. We'll discuss the idea of HAGMAs, high anion gap metabolic acidoses. We'll talk about that next week, so don't stress. Again, same thing. So look, irreversible reactions, those are going to be those unidirectional reactions, these three: glucokinase liver, hexokinase muscle, PFK1, and pyruvate kinase, all unidirectional. When do we make ATP? phosphoglycerate kinase and pyruvate kinase. You're making ATP. Okay. Mitochondria, aerobic, and then anaerobic. You can't go anywhere except the cytosol. So you end up with making lactate. Okay, I'm doing this quick because I promise you guys the questions for this are going to be super easy. You really need to focus on the other stuff. And they know that the reason it's like that is because you have a whole 4-week module on looking at all these different pathways. So yeah, y'all only have like a week or two between term 1 and 2. That's rough, but yeah, we'll get there. We'll be there with you guys, so we'll help out. Anyway, aerobic processes, definitely you need it in the brain. You always need ATP in the brain. Liver just has an abundance of glucose, and the heart always needs to have ATP to contract. So I wouldn't even really worry about these numbers because you do all full calculations in term 2, but just know that glycolysis aerobically is going to yield many more ATP than anaerobically. And even this 8, if you do it aerobically, you go through the Krebs cycle, you end up making like 32 or 34, whereas you kind of have to stop at this point with anaerobic conditions. All right, try this one. All right, so glucose entry to red blood cells, we're using one of those GLUT transporters, right? Does anybody know which one we use for red blood cells? I think I have a slide, but all of those GLUT transporters use facilitated diffusion. Yeah, right, GLUT1. GLUT1 in red blood cells, GLUT2 in the liver, GLUT1 and 3 in the neurons and brain, and GLUT4 is insulin dependent. GLUT5 does fructose, but GLUT4, remember, is insulin dependent, so you use it a lot in the muscles. Once you have insulin there, it'll help the muscles take up the glucose. So keep these in mind, but GLUT1 is in the red blood cells. All facilitated diffusion, they grab it and just bring it down its gradient, okay? Diffusion doesn't require ATP. All right, try this one. All right, and this kind of pointed out a little bit earlier. Remember, if you remember back, it seems like forever ago, I bet. Lower Km, they're inversely proportional, equals increased affinity. Put A for affinity. All right, increased affinity. So you want increased affinity for glucose in the muscles. Whereas glucokinase Vmax, increase Vmax, and means increased capacity, right? And that's going to be your glucokinase. Right, so lower Km for hexokinase so that it has a higher affinity. So increase Vmax because in the liver, you want to grab onto all the extra glucose so you can deal with it however you want to deal with it. Break it down, store it as glycogen or whatever. All right, and this kind of describes what we were talking about. Try this one. All right, so what did we say? Met hemoglobin is a problem with iron, right? You can't reduce it back to ferrous iron. So the problem is iron is in the ferric or +3 state instead of the ferrous or +2 state. We need it in the ferrous state to properly bind iron. What do we give patients with methemoglobinemia? Anybody? Methylene blue, very good. Yep, blue, because they're blue people, methylene blue, right? And this is the process. You give methylene blue to convert this back, to reduce it back. So there you go. Try this one. Right, now why is this? Okay, pyruvate kinase deficiency is downstream of the 2,3-BPG. So we're going to get a backlog, means increase BPG. We know this is an allosteric effector, which means it's going to promote offloading into the tissue. If we're offloading into the tissue, the hemoglobin has to have a low affinity because it has to give it to the tissue. Okay, super important. Make sure you understand this for the exam. Right, okay. Now the opposite's true for hexokinase deficiency. So like for hexokinase deficiency, it would be like this one, right? A left shift for hexokinase because you have less 2,3-BPG. Same slide as earlier. That's the process of making it. All right, try this one. This is kind of one of those things, if you came across it, you'll know it. But you're just asking, what's the deal with fluoride? Yeah, this is that tricky step. This is the process of what fluoride blocks. Sorry, I went kind of quick. Let's all look at that. This is that conversion to phosphoglycerate to phosphoenolpyruvate. Right, and you can see that here. So you definitely know these enolase, fluoride will block enolase for this pathway. Arsenate or arsenic, if you heard of arsenic poisoning, will block this pathway. Again, this will come up over in DM when y'all get there, but I think this is fair game for this test. All right. Try this one. I think we're almost done. Everybody knows this now, right? Bladder's an organ, right? And sensing fibers, right? Sensing things from an organ. Afferent, afferents are sensory, visceral afferent, okay? And you can see that here from the skin, afferent comes in, spinal cord, and goes out to the muscle. So skin kind of tells you what's going on, right? It goes up to the brain, and then the brain comes down and tells the muscle what to do. So A's in, E's out. Try this one. Yeah, good. So definitions here. Eupnea, U is kind of normalized, A is not breathing. Disp is difficulty, tachy is increased. Good. You can see that here. I mean, y'all can try this one. This one's a pain. You got to use math for this one. Go for it. I don't even remember how to do it, so I think I have an answer coming up. But if y'all remember your equations, y'all could do it. This calculation. I'm too tired to think about this, but whichever one this is. How about we just look at the answer? That sounds like fun. This is the equation, this VD over VT ratio. I think they put this on our BSCE, which is not cool, but yeah. So yeah, figure out your calculations, 50 minus 30 over 50. So that's your dead volume versus over tidal volume ratio. What are we working with? So 0.4% or 40%. All right, try this one. Perfect. Yeah, blood flow distribution. That's why you have baroreceptor reflexes. This is called orthostatic hypotension. If patients are dehydrated and they stand up and they feel lightheaded, their blood pressure drops, that could happen. But that's the idea of your baroreceptors. They help to vasoconstrict when you stand, and it helps with blood flow. Your brain's up top, right? So you got to vasoconstrict to get blood up there when you're standing. Y'all will get into that more later. But yeah, this is again what we talked about, this ventilation perfusion. So again, once you get to this lower zone right up in here, that's kind of where you get proper VQ exchange. All right, try this one. Remember, I don't know that I pointed this out necessarily. When the hemoglobin is relaxed, it's relaxed, so it's opened up, so it can kind of bind oxygen when it's relaxed. When it's taut, it's going to be tight. Taut means tight, and it's not going to have the binding pockets open for oxygen. So yeah, so if it's taut, it's opposite of oxygen, and the opposite of oxygen is carbon dioxide. So when that carbon dioxide is bound, it's taut. You're not going to have carbon dioxide and oxygen bound at the same time. Okay, so carbon dioxide's there. It's going to bind up the hemoglobin and keep it in a taut form. Right, again, we're hit on this a lot, so make sure you understand that. All right, fantastic. We are done. Like we said, we will go ahead and plan to do the renal exam for you guys on Saturday, so that y'all have time for, I don't know what I'm talking about.
Renal exam Saturday, so you can study for the weekend and have a day to.
Yeah, that. We usually post the signups on Wednesdays, so that's the plan. We'll do it on Wednesday, and then we'll plan for it on Saturday. All right, good luck, guys. Message us if y'all have any questions.
Yeah, good luck.
I'll go ahead and post the recording a little bit later, hopefully today. And yeah, just message us if y'all have any issues. We'll talk to you guys later.
We believe in you. You'll do great.